Hello everyone, today we're going to go over how to give intramuscular injections. So before starting, it's important to have a plan on the amount that you're going to give and if you know what you're drawing up. So kind of a quick check that you can do is check, look, draw, check, change. So check the dose that you're going to give, look at the syringe and figure out where you're going to draw it up to, draw it up, double check the dose, and then change the needle. So here is an example of a syringe. So say I want to give 1 ml of a drug. I'm going to look at the syringe, figure out where that 1 ml is, and it's right there, and that's where I'm going to draw the drug up to. So your landmarks, there's kind of two common sites for IM injections. It's the neck and the semimembranous semitendinous, which is the kind of the hamstrings of the horse. So on the neck, you have the landmarks of the nuchal ligament, which is the one across the top. You have your cervical vertebrae, which is the line on the bottom, and then you go in front of the shoulder, which is that vertical line. So anywhere in that triangle is safe to give a IM injection in the neck. Those are kind of your three landmarks that you want to feel on the neck before you give an injection. For the semis, you're going to go below the point of the hip in the upper third of the muscle group. So it's somewhere in that square of this picture. And kind of a technique to do this is you're going to stand right up close to the horse's hind limbs and make sure that you're nice and close in case the horse does kick. The closer you are, the safer you are. And then you can kind of bump your horse's, the area you're going to inject, and then put the needle in. And then that should be good to go. The biggest thing is you don't want to surprise them with that sharp needle, so doing a couple of bumps with your fist before pushing it in will kind of desensitize that area. And yeah, so now that we can know the injection sites, we can inject. So when you're going to give an IM injection, you're going to insert the needle perpendicular to the skin. When you inject, you always want to pull back on the plunger to check that you're not in a blood vessel. And if you are, it's okay, don't panic. You'll just pull the needle back a little bit without coming out of the skin and change the angle. The skin poke is kind of what they resent the most, so you just don't want to pull all the way back. But if you do, that's okay. Just poke again in a different spot. And a big thing is that you don't want to inject more than 15 mils in one site. So if you're injecting a large volume, you're going to either want to poke again in a new spot or redirect, as we talked about above, with the in case you get any blood. So you'll just pull back the needle without coming out of the skin and change your angle and insert it again. And then again, as always, you're going to aspirate to check. So some safe needle handling, which is also important, is that you want to have a container to dispose your sharps in. Either you can dispose the whole needle in the syringe, or you can take the needle off of the syringe and dispose of the syringe separately. Or if you're going to do that, some methods of recapping the needle is to place the cap on the table and slide the needle into it and then push it together using the edge of the table. Or you can use the 90-degree angle approach where you line up the cap with the end of the needle, and then you're going to just kind of bring the cap up and drop it onto the needle, and then you can push to secure. These are kind of two methods that can ensure that you're not going to accidentally poke yourself when you're recapping a needle. But if you're worried, just get a container and throw the needle in the syringe directly into that container. So some risks of IM injections is that you might get some pain or stiffness in the injection site. You can get potential abscess formation when there's a reaction to the drug. And you can also damage underlying structures if you give it in the wrong spot. So this is why knowing your anatomy and kind of where you're going to poke is so important. So when in doubt, you can always refer back to a diagram or look it up. But for the neck, we can go back and review that one more. So just to go over the IM injection sites on the neck again one more time, because this is the most common place that we give intramuscular injections and the most common place that we tell owners to. It's just important to go over it one more time. So first you're going to look for that nuchal ligament, which is that arrow across the top. You're going to look for the cervical vertebrae, which is the arrow along the bottom. And you're going to go in front of the shoulder, which is that vertical line. That's going to make a nice triangle. And you can give an intramuscular injection somewhere in that triangle. It's also important if you're giving multiple injections over a few days to alternate sides of the neck that you're doing. So one day do the left, the other day do the right. And you can also include the semis into that rotation as well if you're giving a lot of injections. But the main thing is when you're doing the IM injections is to be familiar on the location you're going to give and the type of drug you're giving, and make sure that it can be given intramuscularly and that you're doing it in the correct spot.
That's Alex, one of our interns, so she can do that for us. Anyone have any other places that they do intramuscular injections?
Between the front legs.
Between the front legs and the pecs, the pectoral muscles, right? Those big,
Yeah.
everyone thinks it's their boobs right in front. Yeah, that's another spot. We don't do that as commonly. It tends to abscess a little bit more is what we tend to notice, so we don't do that. Any other places that people will do intramuscular injection? I know some people, yeah, up higher, yeah, the glutes. So they'll do it right in the bum, on the top, right on one side or the other, if you're looking at the horse from the back. We tend not to like doing in that location. The reason being, if they do get an abscess up there, it doesn't drain very well. So it's kind of gravity is against you. So, but that is most horses you can't get away with it, and you're going to develop an abscess. But I tend to be a little bit cleaner if I'm going to have to do that area. I tend to clean, make sure I'm changing my needle, just to try to avoid that because it is a bit of a risk up there. But it's a lovely big muscle group. So yeah, that is another one that we'll use. But another trick I tell people is right at night. So if you're having to inject twice a day, do the right side at night, left side in the morning, right at night. So then you always forget. Anyway, that's another trick. Okay, our next one, next presenter is Dr. Jillian Hannon. So she's our internal medicine specialist that we have at the clinic. So some of you, if you come to the clinic with a really sicky, you'll probably see her. And she's going to go over strangles.
Where do I click?
That's your next.
This one, and then do I have a pointer?
Yes, back in the
Perfect. Hello everybody, can everybody hear me okay? Sorry? Louder? How about there? Better? Okay, I'll keep yelling. So my name is Dr. Jillian Hannon, and I will be talking about strangles. Trigger warning: if you're squeamish, you don't like gore or purulent material, otherwise known as pus, look away, because this presentation is full of gore. Okay, yay! We have people who enjoy this. Okay, perfect. Well, I just wanted to point out this picture here. Obviously, you can tell that's like an old school picture. And it literally depicts strangles, horses with strangles, and we'll go through everything as to obviously why horses look like that when they have strangles. So quick outline, we're going to talk about what is strangles, we're going to talk about the clinical signs, diagnostics, treatment plan, complications, because obviously I will see those types of cases at the clinic, some biosecurity things, prevention, and some resources, tips and tricks that you can look up easily at home if you have any further questions. So first again, what is strangles? Well, strangles is an infectious disease caused by a bacteria. And the name of this bacteria is Streptococcus equi, and we typically call it strangles. Some people will call it strep equi. Some people, back again in the olden days, used to call it distemper, if you might have heard of that name before. And the name strangles comes from the primary symptom of the disease, in which the lymph nodes in the back of the throat are basically swelling so much that the horse is strangulating. So that's why, again, we have been using this word strangles for so long, because again, it really depicts what is happening in the horse. And strangles in itself is also one of the oldest diseases known. 800 years ago it was already described. And we still have horses with strangles. So very difficult to eradicate as well. And we'll touch on that, why that is in a little bit as well. So as I mentioned, we have abscess formation in the lymph nodes of the head and neck. And there's lymph nodes everywhere in the body, right? Those are the biggest ones in the head and neck area, but there's all little small ones everywhere. And then of course strangles, why are we concerned about it? Well, it is very contagious between horses, right? So if one horse gets strangles and we are in direct contact with another horse, that horse is probably also going to get strangles unless it has good immunity. Then again, with strangles, we can also get complications. And in about 20% of the horses that get strangles, those cases will develop some complications. And those complications can be fairly mild or simple, or they could be life-threatening and cost a lot of money. And then again, the biggest reason why 800 years later we still are dealing with strangles is because we have those asymptomatic carrier horses. So the horse has recovered from the strangles, but is still carrying the strangles. So you take it back to the show ring, you go back to the arenas, you go back to clinics, and every time a little bit of mucus comes out, and we're just spreading the strangles. And again, susceptible horses are going to get sick again. So finding those asymptomatic carriers is very important to again eradicate, or ideally eradicate, but at least minimize the risk of spreading it. And we'll see how the noise here is working. I just wanted to show you this video. Where's Mark? There is no play button. Is there a play button on my screen, maybe? No. 1 second. Okay, perfect. Oh, beautiful noise. So if you look at this horse breathing, when it's inspirating, those nostrils flare open. And that's when we hear the noise. Because obviously when we are inhaling, we take a lot of breath in. So again, if our upper area is obstructed, so in the back of the throat, there is compression for, again, whatever reason, but in this case strangles, we're going to make that noise and we basically sound like Darth Vader. So if anytime your horse sounds like Darth Vader, that's not a good sign. This is the first gory one. The snot is pouring out. Again, the horse is really trying to inspirate. It also has trouble swallowing. It's like... Saliva is kind of dripping out of its mouth as well, because again, it's really sore to swallow. And then we have that big abscess that is draining underneath the jaw as well. So again, that picture that I showed you at the first part, the hand-drawn picture, that's really what horses look like with strangles. They're looking sickly and have a lot of stuff happening in their head and neck. So we'll talk about some classical signs of strangles, as I like to call it. Basically, this is an acute strangle situation. So a horse has been totally healthy, now has been exposed to strangles, now it's going to start having these clinical signs. The first clinical sign, however, will be fever. Well, if you don't take a temperature, you don't really know if your horse has a fever, right? So again, it's always good practice to know exactly where your horse is at with its normal temperature. So that if you notice, oh, my horse is looking a little bit dumpy, or he didn't finish his food, the first thing that you should really do is check its temperature. So a fever is considered a temperature above 38.6 degrees Celsius. So again, that will be the first sign. Then once the strangle starts producing those abscesses in the lymph nodes, we'll start to see some swelling happening. And sometimes that can take a couple days, and sometimes, the swelling is immediate. So we will see, again, we can have the lymph nodes get bigger underneath the jaw. Again, there's all little lymph nodes around the face. Sometimes they have basically straight pus coming out of their eye because there's a little lymph node that exits into the eye. And then again, the back of the throat area there as well, they will have the big lymph nodes, so-called the retropharyngeal lymph nodes. And that's typically when we see the horses standing with their head and neck outstretched, because they're trying to relieve some of that pressure. And again, like I said, sometimes they will have some difficulty swallowing because, again, there's a lot of soreness and swelling in the back of the throat. Think about when you had strep throat for the last time. You could barely swallow probably. So it's really, really discomforting for the horse. The purulent discharge starts when we have the abscesses rupture, right? So first the abscesses have to mature, so they have to get bigger and filled with pus. Then they have to break open. So similar to that last horse in the last video, we obviously had the abscess burst out under the jaw, and then we had the abscesses burst out of the retropharyngeal lymph nodes. So the ones in the back of the throat, they swell up and they break open into the guttal pouch of the horse, and then they start draining out the nose. So that's why we see all that purulent material out of the nose. And when we think about our incubation period, so from when a healthy horse is exposed to strangles, how quickly do the clinical signs develop? Again, depends a little bit on the horse's immunity, but it can be as little as 3 days to 14 days. So even if you had a horse with strangles on the property, you already removed that horse from the herd, not everybody is safe until we kind of pass that 2-week mark, because again, the incubation period, so when do we actually start to see clinical signs, can be quite long.
Excuse me,
Yeah,
did you say 20 days maximum or
14, 1-4.
Or one?
Yeah, 1-4. And as you probably know, strangles is most commonly seen in the young horses. And why is that? Well, again, because A, they have not seen strangles before, and again, they have a poor immune system compared to our older horses, middle-aged horses. And then, of course, the older horses are going to be prone again because they haven't seen strangles for 20 years potentially, so their immunity is way low, and they are also potentially a little bit immunocompromised because of their older age. Couple more gory pictures. So sometimes you will see truly it's the mucus and the purulent discharge that is coming out is really yellow, really thick. Again, classic strangles. Yes, we will also see it in foals. So especially if the mares are obviously infected with strangles and there's a foal outside, the foal is going to get sick unless, again, it had good immunity, which if the mare got strangles, then probably the foal is not going to have immunity. Sometimes, again, in the beginning of the disease, when they're just getting sick, they're kind of having trouble swallowing. Again, those abscesses haven't ruptured yet. Therefore, we're not going to see that yellow pus. We might see just regular mucus. So anytime when we have nasal discharge on a horse, again, we are always thinking about, infectious diseases, contagious diseases, because again, it's very important that we try to contain things as best possible. So some diagnostics. Well, as veterinarians, again, we make a lot of presumptive diagnoses based on the history, clinical signs, sicklement of the horse, obviously farm history, disease history, all those types of things. So you can make a presumptive diagnosis and basically say, yes, your horse has strangles. This is what we need to do. But you can obviously test for it as well. And there's a couple different testing methods. You can obviously take a nasal swab. Again, really good for when we have that purulent discharge coming out. If we don't really have that purulent discharge coming out just yet, you might get a false negative because we're not really catching the bacteria yet. We can do a little bit of a deeper swab, basically in the nasopharyngeal area, which we'll touch on here in a second. We can do our guttal pouch flush or swab wash, where we actually go into the guttal pouches and take a sample from where it's basically the closest to the ruptured abscess. And of course, if we have any lymph node that is already open and draining, we can obviously take a sample of that purulent material that's coming out. And we can either submit that to the lab for bacterial culture, so we're actually growing the bacteria, or we can do PCR, which is basically a machine that looks for the DNA of the strangle's bacteria, which is typically a little bit quicker as far as giving us results back. This is a picture where we're scoping a horse with strangles, and we're actually doing a guttal pouch flush wash. So that's one of my favorite ones and the best test really to either, obviously test at the beginning of the disease, but also test at the end of the disease. And again, we'll touch on that in a little bit as well. So as you can see, my scope is going up the nose. It goes all the way into the guttal pouches. And then I have a little flush line with fluid here that goes through the scope. And I'm basically flushing the pouch, and then all this gunk basically is coming out, and we catch that sample and then we submit that for testing. So I'm going to touch a couple steps on anatomy real quick. This is a picture of an endoscope looking at the back of the throat of the horse. So you can still hear me there. This is the breathing hole, so the trachea. These are the arytenoids, so this is called the larynx in itself. This is the epiglottis. These are the vocal cords, these little white strings. The opening to the esophagus is in the back there. So this whole area is called the pharynx. So as you can imagine, when we're breathing in, obviously the breath has to go into the trachea. When we're swallowing, this little epiglottis flap flips over, protecting the airway so that we don't obviously inhale food when we're swallowing. And then the food, goes down to the esophagus, to the stomach. So that's an important part because, like I said, when we have strangles, the horse is potentially strangulating. So we always want to make sure that that breathing hole is open as much as possible, right? Because it can't get any bigger. It's actually quite small. And then this is just a view just dorsal to that, so just at the top part. So again, here in the back, we have our breathing hole. This is again the upper airway pharynx area. And then as you can see, we have these two little white little flaps. Those are actually the entrance into the guttal pouches. So as you can imagine, if I have a lot of purulent material in there, that purulent material, you can kind of see a little string there, has to kind of slide out, and then either what will happen is the horse will swallow it, or it will drain out of the nose, typically when their head is down. And again, just a side view, I guess, of where the guttal pouch actually is on a horse. It's obviously a big air sac that we don't really know why horses have that, but horses are special, so I guess that's why. It causes a lot of problems. I wish they did have them. And actually, some other animals that have guttal pouches are tapirs and rhinos. And this is just a quick, I'm not going to talk about it a lot, but a quick inside view of the guttal pouch itself. And I want to just point out one important structure. This is when I'm scoping into the horse and I'm looking up. So the guttal pouch has what we call medial compartment and a lateral compartment. And that compartment is divided by the stylohyoid bone, which is actually a bone that connects to the skull all the way down. If I'm looking on this one, all the way down, and then it connects to the tongue bone. So when the tongue is moving, this joint is moving at the skull. So it's a whole long apparatus. And at the bottom of the guttal pouch, we have the guttal pouch floor. And I want it to be exactly like this picture. This is a healthy horse, nice and smooth and flat. If I have strangles, there's going to be a big swelling here from the lymph node, and I'm potentially going to see pus, right? We'll touch a little bit on treatment, and then we'll go into the nitty-gritty of things as well. Really, what is the most important? Well, supportive care, because like I said, those horses are not feeling well. They're sickly. They might have a fever of 41 degrees, which is never fun. And again, they have troubles eating and swallowing. And obviously, we want to protect the other horses. So any sick horse obviously strangles horse right now, we're going to have an isolation, so we're not going to have any nose-to-nose contact, ideally, with other horses. We're going to give the horse anti-inflammatory pain medication, so your Banamine, your Flunixin, your Bute is the one that you're going to give to basically help bring down the fever and cause a little bit of relief in the back of the throat so that they feel better and more comfortable eating and swallowing. If the abscesses are not bursting open yet, you can help them ripen basically by hot packing. I typically just put a bag of oats in the microwave for a minute, then you have a nice hot bag, and then you put it on that area for 5 minutes or so, just to kind of help that abscess form. Feed and water, obviously important. So if they're having trouble eating hay, well, feed them some soaked hay cubes, for instance. Anything that is soft and smooth is going to go easier down the back of the throat and makes it easier for them to swallow. Anytime we see feed come out of the nose or water out of the nose, that's a bad sign, because that means we're so sore or our nerves are so inflamed that we can't swallow properly. And again, that will be an emergency type situation. And obviously we're not going to use the horse, they're sick, so we're going to be resting them. And then again, we're going to be retesting them or testing them for the first time if they were not tested initially, because again, of our asymptomatic carriers that we want to catch. Then I'll touch a little bit about complications. So again, one of the biggest ones that we would be most concerned about, which is a true emergency type situation, would be that respiratory distress. Because again, horses, they can't breathe through their mouth. So again, if there's something obstructing in the upper airway, there's no other way for them to breathe. So they need an airway basically pretty quick. Again, the other one is that prolonged shedding or carrier status of a horse, and we'll touch on that. We can also get immune-mediated diseases, specifically immune-mediated vasculitis or purpura, you might have heard of. And of course the dreaded metastatic strangle, so when more lymph nodes, so lymph nodes behind the head and neck, are going to start abscessing as well, and we call those internal abscesses. So we'll go over these individual ones. So respiratory distress, like I said, is definitely an emergency. We need to provide an airway. Well, how do we do that in a horse? We give him another breathing hole, and that's by means of a tracheostomy. So we have to make a hole into the trachea, put a tube down so that they can breathe, and they get immediate relief. It's pretty amazing how horses can be so distressed. They don't feel well, they don't want to eat, they don't want to drink, they're just focused on trying to breathe. You give him another breathing hole, and boom, it's like a new horse. He's like, oh, finally some relief. Now I can eat again without feeling like, again, I'm not getting any breath. And then of course we have to find out, well, why do we have such respiratory distress? Is it because there's still abscesses in there that need to be opened up? So in this case, as you can see, this abscess is right at the back of the throat, so a pretty, important part. So in this horse, again, we had to help opening that abscess, because it was not bursting on its own, by doing a surgical lancing of it. And then depending on how sick the horse is in general, we might add antibiotics. Again, ideally for a classical, quote-unquote, simple strangles case, we really do not want to give antibiotics. We want them to go through the disease, get better, clear the infection, and have good immunity. So if you remember the initial picture that I showed you, we had a nice breathing hole. In this one, we don't have a nice breathing hole, and you can see that the whole dorsal root there is compressing that breathing hole. So this horse is already struggling to breathe because there's a lot of swelling in those guttal pouches. And then when we actually scope the horse and look into the guttal pouches, well, what do you know? What do we find? We find a big lymph node and the start of purulent material. So this abscess is just rupturing through. So again, this whole area should be nice and flat and smooth, light pink, and it's all red, inflamed, and obviously, starting to produce that discharge. Which, it's a good sign when they rupture. it's not good when they don't rupture, because then the swelling is just there forever and ever and ever. Another example, again, very difficult spot, big abscess, right kind of below the ear, towards where the head and neck are conjoining, if you will, causing compression. And you can see this horse already has a trach in, because that's the first thing that we have to do, give it a breathing hole. Then we deal with the abscesses and all the things that we have to deal with, because obviously we don't want the horse to pass out and potentially die from not getting oxygen, right? And then we get to the nitty-gritty part of things, and we start to lance abscesses. If you're squeamish, look away. So yes, sometimes they need a little help getting those abscesses to burst open. And this horse is totally calm because it can finally breathe again. Obviously it has local block and everything, but it's unsedated. So this horse will just let you do that because they want relief. And if you notice how thick and how yellow this purulent material is, right? And again, that's one of the reasons why we have so many carrier animals, because you can imagine this thick pus just sitting in the glottal pouch, which is just an empty air sac 1 second, and it has to drain out. Well, if it's this thick and gooey, it's very difficult to drain out. Yes? Say that again?
Like it's lance a little high, and I just wondered, would it be, how come so high? The lance
Yes.
is not lower straight?
Yeah, so the question is, why am I lancing this abscess over here? Well, this is a different lymph node. So the lymph node that is under the jaw, that sometimes needs help as well, is going to be about here. This is a lymph node that is basically just sitting below the ear, upper cervical lymph node, you know, whatever you want to call it. But this one got massive, and this one was the one that was compressing the horse. This horse actually already had the submandibular lymph nodes rupture and was already, you know, doing pretty good, until this one just got bigger and bigger and bigger and was not bursting, because there's really no way to burst out. This is just really literally under the skin. Oh, puncture it? No, we picked the spot where it's going to be the best. So I obviously ultrasound, because I don't want to stick it in a blood vessel, and then have to call the surgeon because I don't do blood. I just do gore. But and then this is just the start of it, right? So we make the incision bigger, and then we flush it, you know, and sometimes we have a drain in it. So this is a really good spot as far as where we felt the safest to poke it, get all the stuff out, give the horse relief, if that makes sense. So then we come to our carrier horses. So a normal horse going through normal strangles can still be shedding the bacteria for up to 6 weeks. So that's why strangles takes a long time to basically heal and get over. And again, one of the main reasons why we want to retest before we take them out back with the herd, or before we take them back out to shows, because if they're still shedding, they might look 100% normal and healed, but if they're still shedding, we're just, again, perpetuating the strangles around in the environment. Like I said, why do horses have glottal pouches? Who knows? They just give us a lot of trouble. So again, the disease will be prolonged if those glottal pouches are not draining well. So when we have actual purulent material that is still quite fluidy in the glottal pouch, we call it glottal pouch empyema. Once that pus gets drier and drier and drier, it will actually form these pus stones called chondroids. And that is basically, you know, the longer the horse has been living with the empyema. And then we need to do a whole lot more. So we use the endoscope to go into the glottal pouches, flush all that purulent material out as much as we can. We can remove some chondroids with special equipment, but sometimes there's too many chondroids in there, like 30, 50, 100. It would take me forever to snare those and try to get them out of the glottal pouch via the normal opening. So sometimes we have to take them to surgery to remove them surgically, or we use a laser and the endoscope to remove them, and I'll show you an image here after. And again, that's why retesting is important. So even if you didn't retest at even if you didn't test at the beginning of the disease, and it was just that presumptive diagnosis, yes, my horse has strangles, that's totally fine. But what we want to do is, before we basically take him out of isolation again, we want to retest at that moment in time, because they might be hiding a bunch of stuff in the guttal pouches. So if you remember that picture where I showed you the little slits of the guttal pouch openings, right? Just above there is just a little area. We basically, with a laser, cut a little hole in there, so we're not using the normal opening of the guttal pouch to get into the guttal pouch. And then we take out chondroids that way. So this is a horse that had laser surgery, and we're basically now going into the guttal pouch, not via the normal opening, to get out these pus stones. And you can see the little Easter eggs. The little Easter eggs that are filling up the guttal pouches, and they're stones in a sack. So it's like taking out marbles, if you will. So they jiggle around and they move around. So as you can imagine, it's quite, work intensive, but again, the whole goal is to get rid of these carrier horses, right? We don't want this horse to perpetuate the strangles in the environment. So yes, it's a lot of work, but we feel much better once we know that this horse is cleared from strangles and is not, again, perpetuating it in the environment. So I come with my little handy dandy snare, and I basically try to basket it like putting a basketball in a basket. And then it's like, slippery little bugger. Try again. And then imagine doing this 30, 50, 60, 100 times, right? Because you can only snare one at a time. And then you pull it out through the hole that we just made. And then at the end of it, we have a bucket full of chondroids. And just to give you an example of the size of these things, this is a 1-inch needle, so that's 2.25 centimeters. So look how big these are. Some are, longitudinal, some are really round, some have just weird shapes. And the actual opening of the guttal pouch itself is a little, alleyway that my scope just fits through, and my scope is only 0.8 centimeters. So I would never, if I could snare them through the normal opening, I would not be able to pull them out because my little tubey part is not going to let them go through. Then another complication that we see fairly often, as far as when we have complications, is called immune-mediated vasculitis. And basically that means the strangles has been overstimulating the immune system and is causing damage to the small blood vessels, and then specifically in the skin, but it can happen in any organ. We just see the skin because we can literally look at the horse and see it happening. So we see swollen limbs, basically from elbows to the feet, from stifles to the feet. We can have swollen heads, which again can cause respiratory signs as well. And then we obviously can have skin sloughing if there has been too much pressure on the limbs from the outside, or from the inside, I should say, from the swelling. And then typically, again, with all our other supportive care that we do, we have to give them steroids to calm down the immune system. We do a lot of bandaging, wound care, etc., etc. So here's an example of some swollen limbs. So you can kind of see, yes, the shape of the legs is quite weird, and that's because it's all swollen, same as in the front limb. And this is a mild case, I would say. Sometimes they're literally, elephant legs. And again, bandaging is very important because we want to get that swelling out of the limbs as quickly as possible. So we prevent this happening, which is a lot of skin loss and skin sloughing, right? And sometimes, you do everything and you still get quite a bit of skin sloughing. As you can imagine, having a wound on any horse takes sometimes forever to heal. Well, same in these areas, takes forever to heal. So this was the same horse. This is at the beginning of the disease. We still have skin flaps basically coming off. And then this is, I think, 2 weeks later, where you can start to see the skin is finally starting to heal. but look how much skin loss there is. That's going to take a while for new, skin with hair to grow over. And an example of skin sloughing on the muzzle. So again, when we have a lot of swollen muzzles, again, we still have that same thing. We have that pressure, and then basically the top layer gets shed. And in this horse, we had even swelling above, the stifle. So we have all lumps, bumps. That's all swelling and basically inflammation from, again, that overactive immune system. Then we come to metastatic strangles. So basically any other lymph node in the body besides the ones in the head and neck that also start to form abscesses from the Streptococcus equi. Most common site is in the abdominal mesenteric lymph node, which is basically smack dab in the middle of the horse's abdomen. Not a good place for drainage. And again, those horses typically don't show those acute signs of strangles, right? Because they probably had the strangles, 3 months ago or 2 months ago or maybe 6 months ago, but they will show other signs. So they will show signs of poor doing, basically. So they might have a fever, they might be lethargic. Weight loss is a big one because perpetuating and growing those abscesses takes a lot of energy away from the horse. And then colic, if we get basically things that are really heavy in the abdomen or things that are getting stuck together. So this is a necropsy video and picture of a horse that had a big metastatic strangles abscess in the abdomen. It was about cantaloupe size, again right smack dab in the middle of the abdomen, and the small intestines were actually adhered to it. So this horse presented with colic. So this is a piece of small intestine. Well, as you can see here, it's stuck. Small intestine don't like to be stuck, so that's why this horse was colicking, every 10 days or what have you. And then we got into the abscess. And as you can imagine, this is not something that you can fix surgically, right? Because we don't want all this pus to be in the abdomen. You can't take that piece physically out like a horse that you would take to colic surgery. So those horses typically, again, if they don't have adhesions and colic symptoms, you treat them with antibiotics for a long, long, long time, even up to a year, which is long, long time. This one is another one. This one, as you can see, now we are in surgery. And this one is actually in the inguinal area of a horse. And we're just, as we mentioned before, going against gravity is difficult. Now the horse is on its back. And we're trying to basically push out the pus against gravity, because obviously we could not do this standing. And this is what the horse looked like. So you can see the massive swollen leg, and that's why it's bandaged. And then this is after surgery, we have a drain in that area, but basically there's an inguinal lymph node here that was abscessing, causing this leg to not get good blood supply or lymphatic drainage. The other leg, as you can see, is totally normal. So this is not a vasculitis situation because it's only one leg. So we had to investigate why this abscess was there. Then we come to biosecurity, which is obviously important. We want to quarantine sick horses. Again, any horse that has a fever, snotty nose, you're not 100% sure, it takes 5 seconds to just kind of put it away, and then we start investigating more, basically preventing the spread, stopping the spread. Testing and retesting, very important. And cleaning and disinfecting, similar as to when we had to all be locked away and washed our hands and wear face masks a couple years ago. It's exactly the same. So I feel like people are way more understanding and grasp things better when you're talking about disinfecting and cleaning and biosecurity. The AEP, which is the American Association of Equine Practitioners, has a lot of nice infographics. So this one is a fairly straightforward one where they basically just kind of go over the things that you should be doing, again, when we are just suspecting the start of a case. Because again, if you can prevent it from spreading into the whole herd, that's the best case scenario, and you might only have 1 or 2 horses sick, but not 20 or 50 or 100, depending on your barn size. Prevention, almost finished here. Again, if you have a new horse coming to the property, don't just put it out in the field with your resident horses. I would have it separated from your resident horses for a couple of weeks, typically 2 to 3 weeks is what we recommend, just to make sure that they don't get sick or show any signs of sickness in that period of time. Ideally, when we buy a new horse, we know if it has had any type of disease, so we know its disease history. And same thing with vaccinations or vaccination history. And the vaccination for strangles, there are 2 different ones. One is intranasal, and one is in the muscle, and that's what we call a risk-based vaccination. So as per your barn and how your situation is, because every situation is a little bit different, your age of horses, in and out of horses, do you go to shows, yes, no? That's why we call it a risk-based, so you can talk to your veterinarian and see if a strangles vaccine is going to be good for your barn protocol. What I just want to mention is when we have an outbreak of strangles, we just, lock the barn, we take care of our sick horses, we make sure that we test, but we do not want to vaccinate them when we have an outbreak, because that's not going to make things better. And if we had a horse that has gone through strangles, let's say at 3 years of age, and now, they have good immunity for 3 to 5 years, so you don't need to vaccinate them right after. But now the horse is 10, and we're like, well, maybe we should start vaccinating again because the immunity might be weaned. One thing that you can do is a blood test called an SEM titer, and that titer basically looks at how good is the immunity against strangles. And if that immunity is still pretty good, well, then you don't have to vaccinate because the horse has its own natural immunity. If the titer is quite low, then yes, the immunity has weaned, it would be good to start vaccinating again this horse. Because like I said, their immunity will wane over a number of years. So some takeaway points. Strangles is a contagious and infectious disease of horses. We want to reduce the risk by preventing exposure to sick horses and or use of vaccination based on your risk-based assessment from your veterinarian and your specific barn protocols. We want to isolate sick horses immediately, stop the spread, as we were all hearing about a couple years ago. And we want to find those carrier horses, so we don't keep perpetuating the disease. Again, I think over time, knowing that already 800 years strangles has been here, and it's worldwide, right? That we're not going to just eradicate it in a couple of years. This is still going to take maybe another 800 years, but hopefully at some point, we would be able to eradicate it, and that would just make my life so much easier. And cleaning and disinfecting, as everybody knows, washing your hands, using hand sanitizer, how important that is to keep you safe from respiratory disease. Same thing with horses, to be honest. Again, resources, you can ask your veterinarian. You can look up on the American Association of Equine Practitioners, the AEP. Same with the Equine Disease Communication Center. They also will show alerts for every state and every province in USA and Canada, if there's any kind of disease outbreak anywhere. And they have a bunch of guidelines, fact sheets, biosecurity info. Again, the AEP has those nice infographics. Those are really easy to print out, put in your barn protocol book or hang in the barn if anybody kind of needs, a reminder of if your horse is sick, you should tell somebody and not just let it be sick and mosey about. And then questions. And I thought this was super fun. Yes.
I have a question about vaccines. Would you vaccine a young horse just to prevent the...
Yes, so the question is about vaccines. I'm going to save that for the next speaker, or the speaker, I'm not sure when she speaks, but Dr. Tamara is going to speak about vaccines. So it will be interesting to hear her take on that.
Okay.
Yes.
Over the years, I've heard the term bastard strangle. What stage is that?
Yeah. So the question is, we have used the word bastard strangles in the past. and we basically just don't use that word anymore because it's a bad word. Um, so it's metastatic strangles. Metastatic strangles. So when we get strangles in the rest of our body, that's the same as what we used to call bastard strangles. Yes?
How well does that bacteria live on things like fencing or in the dirt or things like that?
Yeah. So the question is, well, how long does this bacteria kind of live in the environment? Good question. So the strangles bacteria can live in water for up to 6 weeks, long time, and in soil for about 3 days. So obviously we have water everywhere. So that's why it's really important for when, the horse has been sick, we're tested negative, okay, we clean and disinfect all the stuff that we were using with the horse, lead rope, brushes, blankets, they go back into the herd. Where the horse was, that's where we want to do our biggest cleaning because that's where we have been shedding it the whole time. So a big water trough, yes, it's going to be a pain in the ass to clean it and disinfect it, but it's really important to have those touch points cleaned. And obviously you cannot clean the soil, so we basically leave that area, clean for about a week or so before we use it again with other horses. Yes.
So, okay, I've been around the horses a long time and strangles, and for some reason I believe that the virus can even last in our cold weather.
Yes.
Even after like winter and freezing, that comes spring, it would still be alive in the ground. So that's some policy.
So the question is, can the strangles bacteria live even in the ground when we are in those cold winters? And I think again, if they have access to water, so even if they're frozen in the water, they can obviously, still perpetuate. I would say the bacteria itself is not that sturdy because if there's strangles right here and I wipe it with a Lysol wipe, it's gone, it's dead. So it responds really well to that cleaning and disinfecting. One more question. Yes.
Is this exclusive to horses, or do other species, like ungulate steer, do they get the same type?
Yeah, so the question is, do only horses get strangles or do other animals get it as well? This specific type, so the strep equine, is just for horses, luckily. And then if you have any other questions, just come find me in the back, okay? Thank you.
Okay, awesome. Oh, this one. Thanks, Jillian. So we're just going to have one of our drug reps from Zoetis, Dr. Tamara. She's going to come up. So she's going to go into a little bit more of a broad discussion on vaccines. So hopefully she'll answer some questions. I know someone had questions about vaccines in general, so she might touch on that. But
yeah, I hope my attention span is long enough to remember the question.
Yeah, that's right.
Thank you, Dr. Jillian, for handing that hot potato off to me. Booting it up.
So you got a clicker here for you. So you just go next. That one.
Okay.
Laser pointers right there.
Is the iBar. Okay, awesome.
Just make sure that's the right one, correct?
That's me, yep.
Okay, perfect. There you are.
Thank you. I don't know, hands up if you feel like your children have ever gotten strangles. I feel like my kids cart that home from daycare on a weekly basis. But like Shannon mentioned, my name is Tamara, and I'm an equine veterinarian who also provides technical service support for Zoetis Canada. And I'm also a horse owner and competitor myself, so I understand the challenges firsthand of trying to keep our horses healthy, both for their welfare and for our enjoyment, right? Nothing disrupts our competitive seasons like illness or lameness, right? When you go out to see your horses, are you often holding your breath until you get out there to see if they're not colicking, limping, bleeding, or coughing, right? Excuse me, I might have a few subclinical signs of strangles today. But what I wanted to talk about today is how we can help enhance our horses' protection against respiratory disease. And like Dr. Jillian had excellently covered, how strangles fits into the respiratory disease picture and the consequences that it can have, I'm going to discuss a few of the other common culprits for upper respiratory tract disease. And just to start out with a few quick stats, for as many gory pictures that Dr. Jillian had, I'm going to have stats and pie charts. So there's not as much snot in my presentation, and we're going to talk about how to prevent that gore and snot. But respiratory disease, infectious respiratory disease, is super common. And when we look at the severe cases, it's estimated that 10 to 15% of equine deaths are due to respiratory disease. And it's also one of the most common conditions for which antibiotic treatment, rightly or wrongly, is prescribed. So when we look at prudent use of antimicrobials, we certainly need to factor in that aspect when we're deciding on treatment protocols. And when we consider prudent use or limiting our use of antibiotics, preventing disease is a better place to be in than trying to cure. And so when we look at what are we seeing, what do our horses get sick with? So when a survey was done, soliciting samples from horses that had signs of upper respiratory disease. So this was fever, cough, snotty nose. Swabs were submitted, and these were the results that came back. So when you look at the different players, about 22% of the time, we're getting back strep equi, so the causative agent of strangles. Another good chunk of the time, 27% of the time, so a little over a quarter. Forgive my Common Core math. I shudder from when my kids start math and I have to help them with their homework, but those are caused by equine influenza. And then we have a good portion of the pie that is caused by equine herpes viruses. So whether EHV1 or EHV4, between the two, that's really contributing to close to 50%, close to 50% of equine respiratory disease. And then when we add equine influenza and equine herpes virus together, that accounts for about 3/4 of our cases of fever, snot, and coughs. And so when we consider equine herpes virus, so sometimes referred to as rhino, this is the most common respiratory disease. And this is labeled as an endemic viral disease of horses. And when we discuss things as being endemic, they're just circulating amongst all horses globally. It's just attacks of being a horse that they are at risk of exposure to herpes virus regardless of where they live. Sometimes there's some little pockets in Iceland that we consider to be privileged from herpes, but by and large, it is a global virus. Our young horses, just like my young children, they're most at risk, and then older horses can also subclinically shed virus. It does have a degree or a variety of disease presentations. So when we look at EHV1, we have the classic respiratory symptoms with the runny nose, the fever, the cough, but we can also get neurologic herpes with EHV1 primarily. There are some reports of it being related to EHV4, but that's very uncommon. So we can have that manifestation, and we can also have loss of pregnancies or abortions in our pregnant mares. So there's a variety of presentations, but definitely the upper respiratory disease is the most common. And what's interesting about EHV1 or EHV4, or maybe makes it a little tricky, is that it becomes a latent infection. And what I mean by that is that all horses are pretty much exposed by the time they're 3 months old. And that virus then hides out in their body, usually in one of the ganglia of the nerves of the head. And then at times of stress, it recrudesces and starts to shed and then cause clinical disease. And so it may be a little uncomfortable thought to think of that right now, there is a good chance that your horse is infected with EHV. That's just part of the disease complex. And then if there's stressing factors, that's when they start to replicate and shed the virus. So this isn't something where we bring in an outside horse that's necessarily carrying it. Any horse anywhere really has a high risk of being colonized with EHV. And then when we consider equine influenza virus, so this is, again, one of the most common respiratory diseases in horses. Again, our young horses are most at risk. And this is really a highly contagious virus. It doesn't have that latent infection aspect of it like equine herpes does. So horses will clear it from their body, but when they're infected with it, it will rapidly spread through barns. And those infective droplets may spread as far as 50 yards or 50 meters or 150 feet, like kind of whatever system we're wanting to look at, but it's certainly, they can expel it a long ways. And then that shedding in animals that are either unvaccinated or have not been previously infected with equine influenza, that shedding of virus can last up to 7 to 10 days. So that's where they're putting a lot of virus out into the environment, into those infected droplets, and perpetuating that spread to other horses. And then that subclinical or convalescent shedding is common. So they've gotten over the initial cough, fever, snotty nose, those clinical signs, but they can go on to shed it after they've appeared to physically recover. So in terms of control methods, we do need to have that timeline in mind and not take them out back to general population too early. And when we look at when the clinical signs develop, it's usually within 3 to 5 days after exposure. It can be a little bit earlier than that, depending on the infective load and the virulence of the particular virus, but it's usually a short time frame after exposure. And just to give you a visual of the damage that equine influenza does to the lining of the respiratory tract, the picture on the left is not a picture of your grandma's shag carpet, but it is a picture of the ciliated lining of the respiratory epithelium in a healthy horse. So this is what a magnified close-up picture of the surface of the trachea and the large airways look like. And those little shaggy bits, those are cilia. And what the cilia do is they sweep things out of the respiratory tract. So this is part of the housekeeping function. And when the body, as part of its defense mechanisms, it secretes mucus, and that traps different particles, viruses, bacteria, and traps them in the mucus, and then those cilia sweep them up towards the throat, where they're expelled out and swallowed, and the risk of disease or irritation from the dust particles is neutralized or eliminated. So that's in a normal functioning respiratory epithelium. And what the influenza virus does is it has a predilection for attacking those ciliated cells. So this is a post-viral, post-influenza infection picture of a respiratory epithelium that has been undergone severe damage. You can see that we now have a bare surface and we've lost those cilia. And so the exposure of the underlying layers of the mucosa and submucosa triggers coughing and some of those clinical signs and some of the persistent inflammation that we see with this disease. But also, we have eliminated that mucociliary escalator. And so what happens in these horses when there's an extensive amount of damage to the respiratory epithelium, we can get colonization with bacteria, Streptococcus zooepidemicus being the major one, getting access to the lower airways. And this is one of the more serious complications of equine influenza, is those secondary bacterial infections. And those are what result in long-term convalescence or potential complications like pleuropneumonia in our horses. Equine influenza virus in a simple, uncomplicated case tends not to be fatal, but when we get into the situations where we have those secondary bacterial infections, that's where a lot of the long-lasting complications or side effects are developed. And so when we look at getting over equine influenza virus, it can be a long road to recovery. And really, we want to think of a minimum of 3 weeks rest and supportive care required for those uncomplicated cases, and longer if that fever persists more than 2 to 3 days. One of the rules of thumbs that I have, or thumbs, I have two thumbs, a rule of thumb, that I have as a practitioner is that for every day of fever that a horse experiences, I like to give them a week off, right? Because I think we've all been there ourselves or in our horses. If we start them back to work too early, that's when we get those chronic coughs and persistent inflammation. So we want to make sure that that damaged epithelium has had enough time to heal prior to them going back to work. Question? The cilia do grow back. Yes, largely it is one of the areas of the body that is renewing. It takes about 10 to 12 days for those cells to repopulate. I think in some instances we may get a bit of scar tissue depending on different factors, so it may not get back to the exact level that it was, but largely it does regenerate. There is a lot of cell turnover. Great question, because as compared to other areas of the body, we don't have that same cell turnover. And so as you can imagine, there's a large potential impact on both short-term and long-term performance. And those horses that suffer those severe infections, as Dr. Jillian can attest, they may be unfit for competition for at least 6 months, depending on the degree of complications that they develop. And so I just wanted to take a minute and just think about some different logistics or real-world math around these transmission of infections. And so I just want to think a minute of the dimensions of your barn, right? Or where you keep your horse, and just say, oftentimes a lot of them are 36 feet wide, right? You have a 12-foot stall on one side, 12-foot aisle, 12-foot stall on the other. Or how big is the riding arena, either indoor or outdoor, that you tend to ride in? Maybe it's a time for a matchmaker service. Who's single with an indoor arena right here? Right? It's on your Christmas, right? I wear a size 80 by 140, right? But think of the dimensions, right? 80 by 140 or 100 by 120, that's a common size of indoor that we're riding in, depending on everybody's budget. I'm pricing out one right now, and costs are not going down. Or your trailer, right? I realize some feel a lot longer when you're trying to back them up somewhere. But, right, we tend to have, a 7-foot wide, 12, 14, 20, 24 foot long, depending on the rig that you're driving. Now, what does this have to do with the price of eggs, Tamara? If you consider these facts, right, like I mentioned, those infective droplets can travel up to 150 feet. Right? So think of when you're in an arena that's only 100 feet long, or your horse is in a trailer that's 7 by 12, or a 36-foot wide barn, right? There's a strong potential for exposure in that area when there's a sick horse amongst them. 10 days is that typical length of time that an unvaccinated horse will shed virus for, and so that they're putting those infective droplets out there. And then even if that infected sick horse is not present, those infective droplets can remain viable in the air for up to 6 hours. So you could be riding in a spot that has no other horses in it, but your horse could still be at risk for exposure if there was a horse in there prior to you being there. And not all of us have the luxury of just having our own facility to ride in, so that is a real common exposure risk for all our horses if they're out and about. And now when we think at horses that are at risk for EIV and EHV, this is a bit of a tongue-in-cheek slide, right? We have horses that are less than 6 years of age, more than 10 years of age, or those exposed to other horses, including horses who travel or live with horses that do. Now that's pretty much every horse, right? When we think about it, there's a lot of overlapping in those little Venn circles. So long story short is that all horses are at risk for equine influenza and equine herpes virus. So what can we do to help protect our horses, right? Dr. Jillian had lined out some of these key ones, and I think I like to divide them into 3 key categories. And biosecurity, I can't overstate the importance of this, right? These are key things that we need to do to protect our horses. So these are the precautions we take to limit the exposure and spread of infectious pathogens amongst our horses, right? One of the easiest ways to keep our horses safe from disease is if they're not exposed to the disease agent at all. So things like tying to your own trailer, using your own water buckets and feed bins when you're out at different places, whether it be a show or on the trail, or instead of using the common facilities that may be available. Or that quarantine of new arrivals, right? When you're bringing a new horse into your property or your operation, that quarantine time is critical. So the biosecurity things are really important to get right, and those are a cornerstone in protecting our horses from respiratory disease. But like we've outlined, it's hard to completely eliminate that exposure, especially when the majority of our horses are carrying EHV in their heads anyways, right? Another important category is proper health and husbandry, right? The things that we do to take care of our horses greatly impact the risk of developing respiratory disease. So things like appropriate nutrition, whether it be those foundational nutrition concepts that are meeting their basic needs, or feeding them specific nutrients that are designed to help enhance the immune response. Those are important, or that's an important facet of preventing respiratory disease. Our exercise of our horses, right? There's lots of work that shows there's a Goldilocks phenomenon in terms of protecting your horse from respiratory disease. Too little exercise, they are going to be at risk. Too much exercise, they're going to be at an increased risk as well. So hitting that sweet spot of conditioning and turnout for our horses is important. Stocking density, right? The number of horses we have in a pen or in a facility is going to impact their risk of developing respiratory disease, both from a spread point, right? If noses are closer together, we're going to increase the risk of them developing respiratory disease, but also that social stress, right? Like horses have that pecking order. So if they are constantly being exposed to that maneuvering of and trying to understand where they are in the pecking order, that's going to increase their baseline stress. And it's been shown that that social stress and having things dialed in appropriately for stocking density to minimize that pecking order issue really reduces their risk of developing respiratory disease. And then housing is also important, right? Both from a stocking density and air quality point of view. But just those basic things do have an impact on what we're doing in terms of respiratory disease protection. And then vaccination is another important aspect. This is where we can use products that really in a targeted fashion, enhance the horse's immune response when exposed to a specific disease agent. And if it helps, I want you to think of, okay, hands up, how many people here play hockey or have offspring that play hockey? Children that play hockey, Well, okay, a few. Okay, you're spending your time with horses and not in arena, but I want you to picture a hockey team that has just come together and they're at the start of their season, right? Like say we have some novice players and this is the first season that they've played together, right? And what do we do with those players to help them have a competitive season? Team bonding. We train and we practice, right? If you've ever gone through a hockey season with your kids, you know what, they play better after practice, right? And some of the most effective drills are scrimmaging, right? So when we get out and face our opponents, we know what to do. We can play as a team. And that's what vaccination does for the immune system. It gives us a chance to practice so that when it faces the wild type infectious disease agent, it's better prepared. Now, every time we lace up our skates and go out and play, do we win the game? Unfortunately not, right? But we're hoping for a winning season. And by vaccination, we increase our chances of winning the game, of not getting serious disease. But in the event that we or our horses do get sick, they're not sick for as long. Or they don't lose by as much, right? Or it's not a completely demoralizing thrashing for the team, right? So think of a vaccination as practicing for a sport so that you can win the game. And so when we look at equine influenza in particular, vaccination can be the difference between 1 day of illness for your horse or a 6+ week recovery, right? So I know if I had to choose, I would rather my horse be sick for a day or less than to face a long-term or protracted disease course. And so when we look at flu-vac, so that is Zoetis's flu-specific vaccination, in our challenge studies, the horses that were vaccinated and then exposed to equine influenza, those vaccinated horses did not develop clinical disease, while 2/3 of the unvaccinated horses did. The vaccinated horses shed less virus overall, and then they also had a shorter duration of viral shedding post-challenge. So those horses that were vaccinated, they only shed the virus for 3.6 days compared to close to a week for those control horses. So when you look at the likelihood or the risk that that sick horse poses to other horses that are around it, we're dramatically reducing that risk by vaccination. And so that was in our lab challenge studies for licensing. But then what do we know from use in the field? So actually going into horses that are living normal lives, exposed to flu in a more natural sense rather than having it straight blown up their nose through a nebulizer. So those vaccinated horses, they're less likely to get sick as compared to unvaccinated barmates. And then are also less likely to experience those severe disease or secondary complications. And so we can limit the amount of gory cases that Dr. Hannon will see if your horse is vaccinated. So is flu-vac protection 100%? No, no vaccine is, but it is a great way to enhance your horse's protection and really reduce their odds of getting sick and also being a risk to other horses. So this is a bit of the commercial break aspect of it. So why choose Flu-Vac Innovator EHV41? So that's our combination vaccine of Flu-Vac and so against equine influenza, equine herpes virus 4, and equine herpes virus 1. And so this is a giant on the market. This is certainly one of the most popular vaccines out there. And then in at least 2 different peer-reviewed studies, excuse me, administering our flu rhino vaccine as a separate vaccine from our larger core antigen containing vaccine, so like when we have everything all in one syringe, we do get a better immune response against equine influenza when these 2 risk-based diseases are separated out into a separate product. We do know that flu and West Nile do not play well together across the board, regardless of what manufacturer you're looking at for your vaccine. So if we're wanting to provide the best targeted protection for flu rhino, having that as a separate shot is our best way forward. And I know the team at Moores really leans into this concept of separating core and risk antigens. And then when we look at how relevant is the strain of EHV41, we're continually evaluating its efficacy against circulating viruses. We know on the human side, those influenza vaccines, there's big think tanks trying to figure out which strains to put in and what's going to be circulating at a given year. Fortunately, equine influenza does not mutate or drift at the same rate as our human influenza viruses, but we do need to make sure that it is relevant against what's out there. So year over year, we test Flu-Vac Innovator against any of the strains that are submitted to the referral labs and to see if there's going to be cross-reactivity or cross-protection. And year over year, these Flu-Vac shows to be protective. So you can rest assured that what is in Flu-Vac is relevant against currently circulating strains of EIV. And we do have Canadian submissions. So when we get flu positives out of horses in Canada, we do our best to submit them. And so we do have cross-reactivity data against things that were isolated out of BC and out of Quebec. So if you ever have your horses break with flu, let us know. We're certainly wanting to include them in our surveillance programs. And so just a couple tips for vaccination, right? We want to make sure that we're giving them at the proper time. And we want to allow enough time between vaccine administration and our heightened exposure risks, right? If you're popping a shot into your horse as it's getting on the trailer to go to the trainers, we're not going to have the protection that we want out of that vaccine when we need it. And so we want to give at least 3 weeks between when the vaccine is administered and our need for that heightened protection. It takes about that time after a booster shot for those antibody and cell-mediated responses to reach their maximal levels. And we do want to observe the recommended booster intervals when we're giving the first round of shots. And so it's usually 3 to 4 weeks or out to 5, depending on what product you're using. But you do want to give the immune system enough time between exposures to properly process those antigens and be ready to have a memory response. And then in some situations, 1 dose a year isn't enough, right? If you have horses that are determined to be at high risk, they're facing a lot of different infectious disease pressure, you may booster those horses every 6 months. And that's probably one of the more common schedules for horses that are at high risk for infectious disease. The other thing to consider is we want to vaccinate when your horse is healthy. Like Jillian mentioned, we don't want to vaccinate in the face of an outbreak by and large. It's just too late in those situations to really try and turn the tides, especially with strangles, and it can confound the testing for strangles in particular. There are some nuances for vaccinating for equine influenza and equine herpes in the face of an outbreak. We can treat that a little bit differently than strangles, but by and large, the best situation is to time your vaccine when your horse is healthy so that we can really get the most out of that vaccine. And then when we look at administration, part of my job is dealing with adverse event reports from injections of vaccines. And so these are some things that I see that help reduce the risk of injection site reactions or even just injection site stiffness. It's normal to expect that our horses are a bit punky post-vaccination, right? If you've ever had hockey practice, you may be a little stiff and sore the next day depending on how hard you went. But similarly, our horse's immune system is responding. So to have a mild fever or a mild decrease in appetite or just looking not quite right, that's just a sign that our horse's immune system is responding to the vaccine appropriately. Now, if it trips over into something that is more pronounced or severe, that's where some intervention may be necessary. But by and large, to limit any degree of injection site complications, we want to make sure that we go deep into that muscle. And the initial presentation did a really good job of depicting good sites for vaccine administration. I would say the neck and hamstrings are the most common sites. Pectorals we can consider on a case-by-case basis depending on the needs of your horse. And like Shannon had mentioned, we want to stay away from the gluteals if possible. And we want to inject into a relaxed muscle belly. When your horse is really strained against that needle, that just increases the velocity of the material coming through the needle or the force with which we have to push things through. So placing the needle and then just allowing the horse to relax before drawing back and then administering the product is useful. And then something that I want to tell you that may be a little counterintuitive to what's been drilled into us in terms of vaccine handling. We've been really conditioned to keep that vaccine cold, right? It comes from the practice. We often bring it home on ice pack and we put it in the fridge. And that's great for long-term storage, but just prior to administration, we do want to allow that product to warm up. There is some things that are incited by injecting a cold product. So just hold it in your hand, allow it to warm up to about room temperature prior to injection. And then just the last hint I wanted to give you for those that are giving IM injections that either for vaccine or other products. A trick that I use for placement is I run my hand down my horse's neck, and I start up high. And when you're up on like the sternoccephalic muscles, like right near behind their poll, you have a really rounded contour. And then as you move down the neck to over that nice flat triangular spot of the serratus ventralis, your hand flattens. And that's where you want to aim for. So, so you go from curved to flat, and that's a really good spot there. So just the hands-on thing that I just thought I'd pass along. And then Shannon is not up here with a hook yet, but just one last thing. In the combinations that we do, separating out those core and wrist antigens is an important aspect. And so our FluVac innovator, EHV41, pairs really nicely with our core EQ innovator, and that's our coverage for West Nile, rabies, tetanus, and Eastern and Western sleeping sickness. So that's just one last thing there. And we do have the immunization support guarantee. The slide didn't make it on here, but in the event that your horse is vaccinated against flu but still breaks with upper respiratory systems, we do have a guarantee in place that allows us to cover diagnostics and then also treatment if your horse is sick with influenza or herpes. So I'll leave you with that. Our questions, Shannon, how are we doing for time? Can I ask that one about, yes, yeah, yes. Quick question, yeah, the young horse question.
I was asking about the young horse and strangles.
Young horse and strangles, and so that's probably one of the more common places that we do see it used because they're not as great on their own. They haven't practiced as much against it. So if they haven't already had strangles naturally, which induces a fantastic immune response that lasts 3 to 5 years in a fairly complete fashion, it is recommended or can be used in that age group. We tend to stay above a year of age. When we administer, particularly our intranasal pinnacle vaccine, we can see lymph node enlargement in those young horses, but vaccination is an effective tool. It does not replace biosecurity and testing and quarantine, but it is a great way to reduce your horse's risk and for how long.
Give one or the
Yes, yeah, all of the products, whether it be the injectable strep vaccine that's on the market or the intranasal, do require a booster in those initial rounds.
And if you give it, say, when they're 3, do you need to do it every year, or you just?
Right, depending on risk, right? Again, like the need for vaccination frequency probably decreases as they get older. Their body is better at fighting it off on their own. So it's definitely a case-by-case thing for how frequently it needs to be done. Okay.
Perfect.
Oh, yeah.
Thank you, Dr. Tamara. I just want to make sure we get to lunch at 11:30, so I'm trying to speed everybody up. That's why we want to get going here. So next one up, wound management and going over a lot of wounds. So this is going to be Dr. Ashley Lamond. She's one of our amazing ambulatory primary care vets at Moore. She's going to come up and entertain us all with some awesome pictures, I'm sure.
Next slide, and that's your laser.
The left side of this thing.
So that's just
Okay,
in the
that's
middle,
laser.
yep.
Okay.
And then that's your next
slide. Okay, sounds good. Woohoo! All right. Okay, hello everybody. My name is Dr. Ashley Lamond. Zero offense taken if you need to get up and get a coffee. I remember lecture days at school. So if you need to get up and take a break, zero offense here, as long as your neighbors don't mind. So do what you need to do to be able to sit and enjoy the lectures. So we're going to be talking about wound management today. So lots of gory pictures, which, let's be real, is why we're all here. So some basic information. We're going to be talking about kind of what to do when you find your horse with a wound, which seems to happen to every single horse owner, some more than others, and what to do when you see that, when to know when you should call the vet, and when you do bring your horse to the vet, what to expect us to do when we see your horse. Can everyone hear me okay? Before I keep rolling on? Okay, thanks. I do tend to be a rambler, as my colleagues will tell you, so I have a timer set, and they're going to wave me down if I start to go over time. But anyhow, so my intern colleagues here are going to be talking about bandaging and wound cleaning in more detail. So I'm not going to go into extreme detail on those, also in the interest of time, because we have lots of gory pictures to look at. So first thing, this is kind of just a layout of what are nice things to have in your first aid kit at home. Lots of bandage material, wound cleaning supplies, latex gloves are huge. Anytime you're handling a horse's wound, you should absolutely be having gloves on. There's bacteria that we can transmit to them from our noses and things on our hands. So the hand cleaning Julian was talking about is important, as well as making sure you have lots of disposable gloves on hand as well. So hopefully this is also available on our social media posts somewhere if you guys want to refer to that. It's just a nice kind of basic outline of what to have, but we'll skip through. So what do you do when you find a wound? So don't panic, because that is going to be the first thing you're going to want to do, but your horses will pick up on your vibes. So try to stay calm, stay chill, and then just kind of think through what your next steps are. So you're going to need to assess whether or not you're going to need to call us. I would say, I'm going to go into some more detail in the next slides about cases in which you would want to give us a call. And then if you do decide that you need to give us a holler, while you're waiting for us to arrive, you're going to want to clean the wound. Ideally, you want to use sterile fluids, sterile saline. Not all of us have that on hand, so cold hosing is usually your next best option, as long as the horse isn't bleeding severely. If the horse is bleeding quite a bit, you definitely don't want to add the hose to that. You want to slap a bandage on there. So if your horse is bleeding quite a lot, you're going to put on a heavy pressure bandage as best as you can. Again, our intern, Dr. Postel, will be talking to us about how to apply a bandage, but you want to apply some pressure to that, and you definitely want to make sure that once you've placed a bandage, if they bleed through the bandage, resist the urge to take that bandage off and put a new one on, and just put one over top. Clotting is a process, and once it starts, you don't want to disturb it, because then they've got to start from square one, and you can disturb the bleeding if you take your bandage off and put a new one on. So just slap another sucker on top to add more pressure without disturbing your initial bandage. If there are foreign objects in the horse somewhere, in its leg, in its foot, in its body, do your best to not remove it. There are sometimes when they do impale themselves on something, which happens more than I think any of us would like, they do sometimes damage vessels, and then when you go, same as people, I'm sure we've all seen ER and things where they say, you know, don't pull it out, because if they have disturbed a vessel, when you remove, like quite often then the object is holding off the blood flow, so then if you remove the object, you let the blood flow, and then you can have some severe bleeding. So if there is a foreign object in the horse, do your best to keep the horse calm and try and keep that in place. If you're not quite sure how to do that, we're happy to give you advice about that over the phone when you call in. So just, you know, try not to move anything until you have a chat with us about the next best steps. And then we also very important to keep your horse calm. That's going to keep their blood pressure low, keep the bleeding down, obviously stop them from traumatizing anything any further. And so snacks are really good for that. So trying to bring your horse into a contained area, you know, if you find them out in the back 40, you know, sometimes that's just where they've got to stay, but if you're able to bring them in, if they're ambulatory and able to walk, and you can bring them into a small pen or a stall, or into a wash bay or something like that, that's often the best place to keep them. And then while you're trying to keep them busy before we arrive, definitely having a hay net or a bucket of feed, something to keep them occupied, can help to keep them calm as well. If your horse doesn't want to eat, that's an issue. You definitely should be calling us, and I'll go into that in the next slides here. So when to call the vet. This is a list of kind of most of the things that we mean you need to give us a call. I'll just add another thing onto the end and say anytime you're unsure. We are never upset with you. You can phone calls are free. You can give us a call and send some pictures to our answering service and see if you think the wound needs to be seen, because we're happy to give you advice on that before hauling all the way out there, or you guys hauling into us. So definitely give us a call anytime you're unsure. But these are cases in which you can be certain that a vet is going to need to take a peek at your horse to deal with the wound. So for sure, if the wound is super fresh, so if you see that wound happen, you know, that's the best time actually, as disturbing as it can be to see your horse give itself a good wound. If it's nice and fresh, we can reduce contamination, reduce the risk of infection, and we increase the chance that when we put stitches in, that the skin is actually going to heal back together. Because the sooner you can get that wound stitched, the more likely the skin is to actually grow and seal itself. The longer you wait, the more the skin edges just sort of deal with what they've got in front of them and don't want to heal back together again as nicely. So we kind of consider the golden period to be about 6 hours from the time that the wound happens. Of course, for many of us, we don't see the wound happen, and if we don't see the wound happen, it's quite often a case of, oh, he was normal when I looked at him yesterday, came out this morning, and boom, you've got a gross wound. So it could have happened anywhere from, you know, the last hour to like 12 hours ago. So I would say, you know, the sooner the better to get a wound looked at, and for sure if you see it happen right away is best. Anytime you have a wound that's in close proximity to joints or eyeballs, that almost certainly will require veterinary evaluation, just to make sure that they haven't, you know, impaired their ability to blink, because then they can get secondary issues with their the globe of their eye. And then joints, of course, we want to avoid having the dreaded infected joint, because that can be a real pain to deal with on top of dealing with the laceration. So anytime, if you have any suspicion that the wound might be close to something sketchy, definitely give us a holler. If your horse has not had a tetanus vaccination in the last year at least, more ideally the last 6 months prior to the wound happening, then you definitely want to get your horse boosted. So if your horse is not up to date on that, for sure we should come out and take a look at the wound and also booster for tetanus. Horses are much more susceptible to tetanus than we are. We get boosted every 10 years or so, if you remember. I typically don't know about you guys, but horses, we like to make sure that they're boosted annually. The environment that they live in, they're much more exposed to the spores of the bacteria that cause tetanus, and tetanus can absolutely be life-threatening, and it's very easily preventable with a simple vaccination that they don't usually react too badly to. So definitely, if we're not up to speed on vaccination, then that is absolutely a reason to have us out. Definitely, if you look at the wound and there's something in there you think you shouldn't be seeing, we for sure need to see that. So that can be bone, internal organs, deep layers of muscle, anything that looks sketchy to you, for sure we need to come out. Profuse bleeding, of course, sometimes they can cut into vessels, and that can mean that we need to actually tie those vessels off in order to stop the bleeding, in addition to repairing the wound. So profuse bleeding, for sure, definitely a reason for us to come out. Penetrating objects, so nails in the foot, impaling themselves on a fence post, all of the wonderful things that horses like to do to themselves and get stuck in them, for sure we need to see those. If your horse maybe doesn't have that big of a wound, like maybe it just looks like a little scratch, but that horse is quite lame, I'll show you an example of that here in a little bit. But anytime they're lame and you don't think they should be for the size of the wound, that's for sure a reason to have us come take a peek as well. Any severe pain to touch the area, any severe swelling around the area, anything like that can mean that there's something happening below the surface of what might seem like a minor wound. That would be a reason to have us look. Any abnormal behavior, so if your horse seems wobbly, I know we talk about looking at their gums, so if their gums should be a nice light to moderate pink color, if they seem to be particularly white, that can be an issue. It can mean blood loss, it can mean shock. So if your horse is not behaving normally, and like I mentioned earlier, if they don't want to eat, that is a major issue too. So anytime your horse is not behaving as they should with this wound, it may be related and would be a reason to give us a holler. They can also bleed internally if they have, blunt trauma associated with a wound. And so we want to make sure that they're not experiencing that, and if they are, we need to fix it. Also, if your horse, like many I've met in my career, doesn't let you touch the wound without drugs, that's the time to give us a holler. We're happy to help you out with that. Because yeah, especially it seems to be the ones that seem to get wounds on their hind legs, seem to always be from kicking something. Those ones, I'm sure I hear some laughs in the crowd. Unfortunately, sounds like you guys have experienced that. Definitely, they don't always love you touching it. So we're here with drugs if you need us. And then, like I mentioned earlier, sometimes the actual laceration itself is just the tip of the iceberg, and there's sometimes things happening below the surface. So determining whether a wound is fresh or old. So the wound on the left, I know I don't have the context of the rest of the horse's body in this picture for you to be able to see where it is, but the one on the left is in a horse's armpit, and so that's a fresher wound than the one on the right, which is on a horse's shoulder with some swelling around it. So the one on the left, we can tell that the wound is fresher because you can see the presence of fresh blood. You can see nice, fresh pink tissue, newly exposed. It's also very frozen, as you can see. But yes, the owners caught this one one right away. They actually almost saw it happen. It was within like half an hour. So they brought that horse in right away, and he did really well afterwards. We got to it right away. But you can see the qualities of a fresh wound with fresh blood, not a lot of swelling, lots of pink tissue, versus the one on the right is embedded in hair. The coloring is kind of, it's got some discharge to it. It's a little bit, the skin is a little bit discolored, if you can see it in between the edges of the hair there. So, you won't see nice fresh pink tissue always. It might be a little bit like beef jerky color, or with a little bit of swelling and discharge. So that means the body's had some time to mount an inflammatory response to the wound, which means it's a little bit older, probably more than 6 hours. This one wasn't hugely older than that, but it does have quite a bit of swelling around it, which indicates it's been there for a little bit. So this is on a horse's hind leg. It was a young mare that was in training and took an unexpected tour around the property due to a spooky moment, and ended up battling with some farm equipment. So you can see, obviously in this wound, there's things you shouldn't be seeing in that wound, right? So it's gone fully through the skin, it's gone fully through the subcu tissue, and it actually went through the superficial digital flexor tendon that's on the back of that leg under the hock, and completely severed it, and did also try to get into the lower hock joint as well. So that obviously, the horse was also super lame on this leg, was non-weight bearing, and so yeah, this would be an example of a wound that we would absolutely need to see right away. You might also, you would want to cover that up until the vet came, just to avoid contamination. You see the wound looks nice and clean though, although it's deep, there's not a lot of dirt, manure, straw, hay, all that kind of stuff in it. The owners did a fantastic job of getting it wrapped up right away. They were present when it happened, and so they could get it covered up and the contamination was minimal. But something like that, for sure, give us a call.
Question.
Yes.
Did they cover it before they cleaned it, or did they try and clean it?
They just covered it right
Just
up.
covered it, so just forget about what you see, get that thing covered.
Yes, that's a great question. So the question was, should they have cleaned it first or just covered it right away? In this instance, it happened really, like they saw it happen. So the wound was not super contaminated when it did happen. So they just slapped a bandage right on there and put her on the trailer and hauled her straight in, which in that instance is the best thing to do. I guess the cold hosing and those types of things in the cleaning is more if you discover it in the morning, it maybe happened the night before, it's a little gooey and crusty and you can't really see the full extent of the wound. That might be when you want to clean it a little bit. But if you see it happen, minimizing contamination is the name of the game, and get them to the vet for sure. Now this one, this wound doesn't look super big, does it? It's pretty little, but this horse was super lame when the wound was found, and so any thoughts on what structure might be right around that little pinpoint wound? It's a horse's front leg from the side. So the elbow joint, I think I hear some people saying, good job. So yeah, this wound, although it didn't look super sketchy initially, it was pretty oozy. There's quite a bit of swelling you can see around here above the bandage, and this horse was quite sore. So we did send this one for a surgical evaluation. Ended up being okay with medical management, but we were concerned for involvement of the elbow joint in this particular case. So although the wound was quite small, it was pretty deep, and it did track towards a scary place. So wounds can be very deceptive. Now, sometimes though, the shining light of hope in this whole presentation, you can sometimes have a wound that looks really bad that isn't as bad as it may initially seem. So this one here is a horse's front leg. You can see it's kind of the distal end of the cannon bone here. Right under there would be the tendon sheath and the fetlock joint and the flexor tendons and lots of scary, scary things. So it is a very scary looking wound. I came in and I was like, when I saw it, because I was like, uh-oh. But when we cleaned the wound and examined it digitally and watched the horse walk, the horse was super sound, super comfortable, very unbothered about the whole thing. Then, oh, there's my halfway timer. Okay, keeping it real. So when we explored the wound, he had just really peeled the skin back. So there wasn't any pocket, there wasn't any deeper section to this wound. And so he really just degloved himself slightly, but all of the tendons underneath were okay and the wound didn't seem to go any deeper. So that did really well, even though it's a very terrifying looking wound. This is a standardbred baby racehorse. They love to do this. We get like 3 or 4 of these a year where they'll trip and fall on their knees and scrape it up. They race on a pretty firm surface. They race on limestone, which is very, very sharp. And so when they do fall, they tear their skin and drag it. So it's right over, it's a little, again, hard to see. A lot of these pictures don't have the rest of the horse in it, sorry. I look at it and I know what part of the leg, but it might be kind of hard to see. But this is front legs. These are is the horse's carpus or knee joint in the front leg. And you can see that it's done a pretty good job of peeling its skin back and filling all of these little pockets with limestone. So this looks like a really bad joint. You know, both knee joints are right under where these wounds are. So you look and you say, oh no, like that's right over the knee joint, oh no. When we x-rayed though, you can see this is a picture of the flexed knee from the side. You guys can see this kind of bright white stuff down under the skin down here. So there's a bunch of skin missing over top of the joints, and there's gravel in there, but it didn't quite make it into the joint space. So although the wound looks really nasty, these horses do well, knock on wood, typically. They somehow manage to avoid having joint involvement, even though the wounds look terrible. So they ooze and spit out limestone for like 3 weeks, and they usually take like 4 to 6 weeks to heal for all of that skin to fill in. So it's a bit of a laborious process bringing them back from this, but typically their joints are okay, at least, which is nice. Good question. So the question is, would I have taken some skin away to debride and get that gravel to come out? The answer is no to that, just in the interest of making sure we reduce the amount of tissue that has to grow back. Because if we were to cut all of that away, then the horse has to heal all of that back, and it takes even longer. So we got a kind of the draining against gravity idea, so it's kind of frustrating, but we do have to get the horse to spit all that gravel up and out. So we assist with that with daily wound flushes and that kind of thing, and just have to wait till the body clears the stuff. Because it would make the wound much, much larger if we had to cut all the way down. But good question. So eye involvement, obviously anytime it's near an eye emergencies in general are a call that day type of problem. So the one on the very left there, the actual eyelids are okay. All of this is like the conjunctiva, the pink tissue under the eyelids. This horse got gored by a bull in the eyeball. So the eye was completely lacerated and damaged and would have never been visual again. Would have taken a long time to heal and would have been painful in the process. So we did actually end up taking that eyeball away, taking it out the next day. We gave her lots of pain medication, kept her in the hospital, put a bandage on that to compress some of the swelling, and then removed the eyeball the next day, and she did fantastic afterwards. But yeah, so that obviously immediate emergency. This one in the middle is a little harder maybe for you guys to see, but there's a little white spot on the bottom of the eye here. I don't know if you can see it. This horse kept her eyelids intact, decided to go for gold, and like sliced her actual eyeball. So she had a corneal laceration, which we treated with intensive eye medications for about 3 to 4 weeks. And she did fantastic. So she did really well afterwards, but the owners, same thing, were super smart. They noticed there was something wrong. She got loose, scraped her eye on something. She was squinting, so the owners brought her in right away. We got on it right away, and she healed up great. The one on the right here is also an extremely common one, seems to be, especially in standardbred babies. They like to catch their eye on bucket hooks or something. I don't know, the air, I'm not sure. But when they do impact an eyelid in this way, it means that they can no longer blink properly. And it's important to the environment of the eye for it to stay nice and moist. And so when you take their eyelid away, you take away their windshield wiper, then they can't do that, and then the eye is at risk of becoming damaged. So these ones need to be repaired as soon as you find them, in the interest of making sure, even if they're found and they're old and crusty, we will still try to stitch these ones together, because we do need to maintain function of that eyelid as much as possible. So here's some example of complicated wounds that stuff you don't want to see in wounds, okay? So a bit of a random collection, but on the far left there, this, again, we don't have the rest of the horse for context, it's a hind limb on the front part of the hind limb, and the horse has scraped right down to the bone. So this is a similar wound, a little more extensive, same thing on a hind limb, had totally scraped away through the skin, subcutaneous tissue, and the extensor tendon. And there was a little bit of bone exposure as well. Now what we worry about when there's bone exposure is that the bone can die off, and then the body will kind of spit it out and treat it like a splinter. So it'll create a bunch of pus around that splinter bone piece and spit it out, and we call that a sequestrum. And if they do develop a sequestrum, it can make the wound take much, much longer to heal. The typical presentation of that would be if you have a wound that, hey, again, maybe didn't seem that big, or maybe was was like this guy here, you wrapped it up, it started to heal, you got tons of pink granulation tissue, awesome, everything looks good. 3 to 4 weeks later, all of a sudden the leg swells back up and starts to spit out pus, and you're like, what in the hay? So you put them on antibiotics, pus goes away, swelling comes down, they do great, they come off the antibiotics, swelling's back, discharge is back, maybe they're a little bit lame. In that case, they probably are going to need x-rays to evaluate that bone and just see if there's any sequestrum or bone splinter that's developed that needs to be removed. Because until that bone splinter's out of there, the body won't heal it. The body's very good at deciding when it's time to completely heal. If it's not completely healing and antibiotics, one round of antibiotics hasn't fixed it, then typically there's something else going on, a foreign body, sequestrum, something like that we need to get to the bottom of. And then this one on the right is a jaw wound. So this was another young standardbred problem children, but they caught her teeth in the bars. And she ripped, there's pictures on the next one here, a little bit better. So she, that's what I was looking for, thanks guys. So you can see here she folded these 3 incisors right down and broke her jaw. So these guys caught this right away again, brought her right into the hospital. This is the jaw from the other side, but this shows how the surgeons will anchor the piece of the jaw to the other remaining healthy jaw and teeth. And that's kind of how we hold the jaw in place while it heals. So she had that wire in, I think, about a month, and did great afterwards. But obviously this impacts her ability to eat. She has difficulty grabbing her hay and things like that. And obviously the longer you leave it, the less likely we are to get that to heal back, and then she'll be missing a piece of her jaw forever. So for sure, immediate intervention is super important if you have a wound like that. So this is a wound that was an example of profuse bleeding. So the horse is not actively bleeding in this picture because unfortunately the horse did not make it. So we don't have any active bleeding, but you guys can see all the signs that there was tons and tons and tons of blood. So this is the back of a front foot. You can see right where my thumb is, there's a very, very deep part to the cut, and they completely severed their digital vessels, the artery and vein in that part, so that's where all the blood was coming from. Again, unfortunately the horse didn't make it, so we couldn't repair it, but certainly with a wound like this, we would be worried about coffin joint involvement, tendon sheath involvement, plus the blood loss. Now, if your horse is has experienced significant blood loss, they can experience so much that they need a blood transfusion, and that can be a whole rigmarole. So for sure, if your horse seems to have lost a lot of blood, they can lose a fair amount without having any trouble or needing a blood transfusion, but there is a line at which they have trouble, living without a blood transfusion. And so for sure, if the blood loss to a wound that you find is concerning you, for sure we should take a peek. So we have a few more minutes here to go through these things. So this, I also showed in my emergency presentation. Yeah, I know, it's a bad one. These guys did the exact perfect thing. So this is actually a front shoe and a hind foot. So these guys did a really good job of calling right away and leaving that shoe in place. The temptation when you find something like this is to rip that sucker out. Don't, please. They wrapped some cotton around the foot and the object to stabilize it until we were able to arrive, because the reason we ask you to leave it in place as well, in addition to the bleeding thing, is because we can also take some imaging to see where the object is going. So this is the hind foot from the side, and you can see that shoe just very narrowly missed the coffin joint. This horse actually went on to do really, really well, didn't need flushing or surgery or anything. We just did some intense injectable antibiotics for a few days and some bandaging, and she came right back to work and was totally fine. Grew out the whole like nothing had happened.
She was from that same horse or a different one?
That same horse. Yep. I'm not sure what type of athleticism caused that to happen, but yes, front shoe and a hind foot. So yes, very athletic horse. But yeah, so it's important for us to be able to evaluate as much as possible where the object went before taking it out. And then yeah, sometimes they've done more than just scratch the surface. So like I was saying, sometimes they'll have a very small wound, but maybe the horse is really lame, or there's a lot of swelling, or there's weird discharge, and you're just like, something doesn't seem right. So this is a horse's shoulder. So this was a really nice, super awesome mare, hugely valued member of the family, as they all are. And she had come in from the field with a very small wound just below the point of her shoulder, but she was super lame. So the wound was only maybe like 2 inches at the very very most, and it seemed partially just a surface wound. You can actually see the gas tract on the x-ray here of where the wound was. So when we looked at her while she was super, super sore, and they can sometimes be like that from nerve damage, but there was a lot of swelling, so we said, hey, let's take some x-rays of this shoulder. So this is kind of a side-to-side view of the shoulder here. You can see this is her elbow and her front leg, her radius there, and then the humerus here, which is the major bone of the shoulder. And then we saw where the gas tract was leading, and we saw a little bit of weirdness right there. That was kind of like there was a line where there shouldn't be a line on a part of the shoulder. So we came around the corner, took another view, and you can see here there's a line that shouldn't be there. That's the deltoid tuberosity. It should be better attached to the humerus than it is in this x-ray. So again, our elbows here, radius here, humerus here. So we went around the corner and did a cranial caudal view. And you can see that fragment, I think I'm pointing at it, yes. So that fragment there is her deltoid tuberosity, and it has completely separated from the humerus. So luckily the rest of the humerus was intact, but that deltoid tuberosity had come away, and there's muscles that attach there, so those had come loose. And so that explained why she was so sore and had so much swelling. So very small surface wound, big trouble happening underneath. So her rehab plan was pretty intense, knowing that this had gone on underneath. This is another view front to back. You can see the fracture here, and then the gas tracking from the wound right there. That's her elbow, front to back. But yeah, so that is an example of what can be happening and how the wound is just the tip of the iceberg. I got one more of those, and then I think we're probably close to time. So yeah, so size does not always equal severity, like we just discovered. So in this case, this was another horse that had, under her hair, this wound didn't actually look very big. The owners got it, it was pretty fresh, but it didn't look that huge, but they're like, wow, she was pretty lame. She wasn't quite non-weight bearing, but she was significantly lame at the walk. And they said, hey, like, there's this little wound here, we cleaned it up and stuff, but she's still really, really sore, even with bute. So brought her in, took a look, and then we discovered when we took x-rays of that spot, I tried to circle it here so you guys could see, she'd actually fractured a piece of the main bone in the hock. I don't know if you guys can see that little line right there. It's not supposed to be there. So we think she got booted in the field is our best guess, and so she had impacted that piece of the bone and broken it off. And then in doing so, had also created a communication between the outside world through the wound and her main hock joint. So there was contamination there for sure. So she did really well with medical management, didn't have to go for surgery, but she did need to be rested for a long time. As far as I'm aware, she came back to work, and didn't have to do surgery, but important to know that this is going on under the surface to explain why she's so lame. So I think I'm at the end of time here in the interest of trying to get you guys to lunch. I have way more things to talk about, so if you guys want to find me, happy to chat about the other half of the presentation. I just got absorbed in here. But yeah, thank you very much for your attention.
I know. No. Have a different one for them? Yeah. Get them hooked. Exactly.
I believe it.
Yeah.
I'm sure I've seen it somewhere.
Yeah, that's right. Good, how are you? Nice to see you.
Oh, yeah.
I recognize, it's always those things, right? I'm like, there's a horse that actually.
Yeah, exactly. You have to say which the horse is.
Okay, so,
Maybe off.
it's myself. Just in the interest of time, and I want to give people these little how-to videos. We're just going to run them. Feel free to go in and out. They'll just be kind of running in the background. But we're just going to go over how to put a distal limb or a limb bandage on a horse, as well as eye meds. So we'll do both those short little videos for you guys, just as little how-tos. But
Hi, I'm Dr. Svea Foster, and I'm going to be explaining on how to clean a wound if you find a wound at your horse at home. First thing you want to do is clean your hands if they're dirty, and clip the hair around the wound. If you have gel at home, it's great to apply some gel around the wound to prevent any hair from getting into the wound. If not, you can do it without. We have already done that. We have already clipped the hair around the wound here. And the next step, if you have any gross dirt or debris at the wound, you can clean it off with some tap water or saline. Get rid of all the dirt that is on there, and then grab some antiseptic like betadine solution or chlorhexidine. We have diluted betadine solution here in the bucket with some gauze that you can just squeeze out and then clean the excess, whatever is around the wound here. In general, you always want to move from the center of the wound towards the outside. Just clean everything. She's a bit itchy on it. Once you think it's clean enough, looks good, just after the swab. We'll change gloves and rinse it off with either some water or saline solution. I only have some gauze with some clean tap water, lukewarm. Just make sure the entire silk is off until the middle of here because it's contaminated. Okay, and then if you have a wound that needs bandaging, you can apply bandage, of course, which Dr. Fran will talk about. If you feel like it needs suturing, this wound is left open because we want it to drain out. If you feel like it needs suturing, or if it's heavy bleeding or really big and you're worried at all, or if it's above a joint and you're worried the joint might be affected as well, always call your veterinarian, of course. Yeah, we'll just apply some Vaseline underneath so that all the pus that's draining out does not damage the skin. Take with a clean glove, of course, some Vaseline, apply it in the hand. And that's it. We also might want to use alcohol, hydrogen peroxide, or always one of these diluted solution. The thing scrub is quite aggressive and convert
Yeah, so I got both the video and
Yeah, I'll do the actual PowerPoint this time.
so that's your next, and that's your laser.
This is my. Can we do it in prison?
Yes. Yeah, so you'll see there, and then can you just hit that to go next, or you can use the arrow key. Up to you.
Arrow key probably because I know how to use it.
Okay, sounds good. That's on for you.
Can I just? Good afternoon, everybody. Ooh, it's moving on its own. My name is Dr. Wood. I'm one of the intern veterinarians at Moore. I'm just going to do a little presentation for you guys on taking a TPR on your patients at home. Some valuable information that you can share either just in general. Is that better? Okay. If I'm too far away, just hold your hand up. I'll try and stay a little closer. Okay, so first off, let's talk about what TPR stands for. So T, of course, stands for your temperature. P is your pulse, or your heart rate. And R is for your respiration, or your breathing rate. So let's talk a little bit about what are some normal values. Sorry, my slides are advancing without me advancing them myself. So why is your TPR important? It's important for getting to know the normal of your horse. Like people, horses can have various variations that are normal for them. So getting to know what's normal for your horse will make it easier to pick up on subtle changes that are occurring. Another thing is that signs of illness and discomfort can be detected earlier through changes in these values that you may not otherwise notice with just other subtle illness signs. So you may be able to pick up a little earlier on that your horse is not feeling as well as they should be. Another important part is that it allows for better communication with your veterinarian. So if you're able to call in, talk to them and let them know what your heart rate, temperature, and respiratory rate are on your horse, it might allow for a little bit better discussion on the phone to kind of go from there as far as treatment. So normal values, temperature in Celsius should sit between 37.2 and 38.6. For those that work in Fahrenheit, that's 99 to 101.5. Pulse, 24 to 48. And a respiration of 8 to 24 breaths per minute. So what kind of equipment do you need for taking your TPR? So a watch or a timer, something that can count 15 seconds for you. It's very helpful. Stethoscope is super nice to have, not essential though, you can do without it. If it's something you'd like to have handy, you can pick a cheap stethoscope up from places like Walmart, your local pharmacy, or even something from Amazon. And then you're going to want to have a thermometer and some sort of lubrication, whether that's some KY jelly or Vaseline. Something that makes taking that temperature a little easier on your friends. So first off, let's talk about how to take a temperature. So you want to use some caution when you're taking your rectal temperature, because some horses can be super reactive to this. So especially if it's the first time taking your temperature on your horse, just be aware. Ideally, you want to have a friend or someone at the head of your horse with a halter and lead rope on. And make sure that they are on the same side of the horse that you are, so if your horse gets agitated or moves away from both of you and doesn't squish somebody against the wall. Also make sure you're in an area that there's no risk to you or your horse, that they're going to step on something, trap themselves in any way. So next you want to stand to the side and gently lift your horse's tail. Slowly insert your thermometer into the rectum and wait for your thermometer to beat before removing it. Make sure not to pull too hard on their tail, as that can cause a little bit of discomfort for them. So before we talk about how to get a heart rate, let's talk a little bit about the stethoscope, for those of you who haven't used a stethoscope before. So some of the key components to your stethoscope that you'll want to recognize are first the ear tips, which should insert into your ear. There's two directions when you look at a stethoscope that they'll point. You want them so that the ear tips are pointing more like towards your nose when you put them in your ears, otherwise it's going to be a lot harder to hear. So next, you want to inspect your tubing and just make sure there aren't any cracks or cuts in your tubing, because that's really going to affect your ability to hear anything. Next important part is the bell and the diaphragm, which is at the very end of your stethoscope. So not all stethoscopes have both components, some only have a diaphragm, but some stethoscopes, that end piece will turn. So that will change which end, whether the bell or the diaphragm that's picking up the sound. So you want to just take a little tap on either side to determine which side the sound's coming from. That's the side you want to put against your horse. So now on to how to get a heart rate. So with your stethoscope, make sure your horse is standing square. If their left leg is too far forward or back, it can adjust where your stethoscope needs to go. It might be harder to hear. So you want to put the diaphragm of your stethoscope against the left side of your horse's chest and position it just behind their elbow as shown in this picture. Count the number of beats you hear within 15 seconds, and you want to multiply the number of beats by 4 to get the number of beats per minute. Side note, if you've listened to your cat or dog, the horse's heart, the lub and dub are very clear. So sometimes it's easier to count 1 and, 2 and, 3 and when you're counting your heart rate, just so that you get the accurate number. So if you don't have a stethoscope at home and you're trying to get a heart rate, you can feel it off of the facial artery. That's located just underneath the jaw, and the location shown in the image here. So you want to gently apply pressure to palpate for a pulse, but don't put too much pressure, you may cut it off and not be able to feel it. Just hold steady there until you feel it beating under your fingers, and then the same thing applies. You want to count the number of beats in 15 seconds and then multiply that by 4 to get your heart rate. So for your respiratory rate, you want to watch the rise and fall of your horse's flank in behind the last rib as outlined by the circle with the eyeballs. You may also be able to feel your horse's breath from their nostrils by placing your hand just in front of their nose. And you may also be able to hear it in the trachea with your stethoscope. You want to count the number of breaths in 15 seconds, and once again multiply that by 4 to get your respiratory rate. You also want to pay some attention to how they're breathing. So are they breathing really heavy? Does it look like they're having a hard time breathing? Is there a lot of abdominal effort when they're breathing? These are all important things to consider and things you want to let your veterinarian know when you talk to them. So now let's talk a little bit about when to consult your veterinarian. So if you can get some variations with things such as temperature that can increase with weather, exercise. You can have changes in heart rate with fear, excitement, and pain. But a horse that's at rest should have a beat of below or around 48 beats per minute. And exercise can also increase your environmental temperature, which can elevate your horse's respiration rate. So there's things to take into consideration. But if you've got a consistent temperature above 38.6, that is concerning. If your horse is just standing, not doing anything, is resting, if their heart rate remains above 48, that's another thing you should be flagging you that maybe we should give your vet a call. If their resting respiration is elevated without any obvious cause, so they didn't just come off the track, they haven't just had some hard exercise, but they look like they've got an increased respiratory rate, another thing to make note of. And as well, if you notice any other abnormal clinical signs or signs of distress along with these, definitely a good time to give your veterinarian a call. Thanks so much, guys, for listening in on my little talk on TPR.
Hello everybody, my name is Franziska Bützler. I'm one of the interns from Equine. You just met Chelsea, one of my colleagues, and I'm from Germany, and I also have some English accent in there, so please forgive me. We'll be speaking about distal limb bandaging, and first of all, why do we even put a bandage on? Well, we already have more than enough wounds that we want to protect, but there's also other scenarios where we would like to put maybe a distal limb bandage on. So any kind of bandage that's below the hock or below the knee carpus. So for example, in cases of cellulitis, that's a very fancy word to say thick leg. So it's a bacterial infection of the skin that causes the whole leg basically to swell up. Of course, you would still like to have your vet consult on that, because just any swelling of the skin could still be like a joint that's infected underneath, and you just want to make sure that's just a skin infection. But those horses can also be quite painful, and you would still obviously like to help them in a way, and distal limb bandages in those cases, or even further up, depending on the degree of swelling, can really be helpful, because by putting that pressure bandage on, we reduce the swelling and also give the horse pain relief in that physical way. Other cases where we might want to consider bandage, depending if we had any kind of joint injections done and we just want to protect that area. Usually it's just needed for the small area, but sometimes in some horses that are prone to flare-ups or skin scratches, we might want to do a bit more than just a simple little bandage. So apart from bandaging, when we put it actually on, so we have basically 3 big layers to our bandage. So the first one is the contact layer. So that's the part of the bandage that's in direct contact with our, let's say, wound. So the material there is supposed to kind of make the best milieu and support of our wound bed in order to allow healing. Because we don't want the wound bed to dry out, which in this weather, it's quite likely if you just leave it out to the air. But also by kind of closing it up, obviously we're keeping bacteria and any kind of debris out of there and allow for the best possible outcome. Another thing that our pressure bandage also does is it allows for immobilization. By not moving, we also keep our wound bed free of any damage, and that once again allows the wound to heal nicely together without quite as much as scar tissue, because obviously if we have wound edges that move around, we need a longer time before it's completely sealed, and also sealed in a way that's stable and will not rip as soon as the horse moves again. For bandages, you might also consider to have your horse on stall rest, because once again, if the horse is out in the field with a wonderful bandage on, it will still move, and that will still be detrimental to our wound healing. Once again, if you have your horse in the stall, you might consider something like a companion to keep it company, because yeah, you don't want your horse to freak out, jump out of the window because it sees its friends in the field. Yeah, that's another call. But yeah, so let's come back to our wound. So after we've kind of protected the wound bed itself by placing something like a 4x4 gauze, or you might also get something like a animal intex or curity pad, so it's a non-adhesive wound bedding, or yeah, kind of square that we put on there in order to not stick to the wound itself. We're going to place some cotton around it, and the cotton on there is supposed to provide some padding as well. If in case we had excessive discharge, it could also absorb that. And then we want to secure everything, so that means where you put our brown cling, which is just a cotton gauze, thank you, and some vet wrap, which is the really, really colorful stuff where you can go crazy. And yeah, it's supposed to keep our stuff in our bandage in place, and then eventually we're gonna seal it up with some light blast. You might find, apart from the light blast that we provide, you could also buy it at Irvine. However, I found that to be very, very tight, because that light blast, what it's intended to do is to stick to the hair, and in order to keep basically from our beautiful bandage that we just put on, in order to get anything not from outside in. So yeah, other stuff you could find at Irvine's. I find them really, really hard, and they're even tighter than the light blast that we have here in the clinic. And you want to make sure to have enough pressure relief, so might even have to roll off the whole bandage before you put it back on. So yeah, this is why we like the light blast here in clinic. And I've put together a little video of me putting it on, since I couldn't bring the patient in. And thank you for the lovely lady who allowed us to borrow her horse for that.
Hi, my name is Dr. Franziska Bützler, and I'll be showing you now how to put on a lower limb bandage. So we have a lower limb bandage with the idea that we protect any kind of wounds or operation sites that are healing underneath here. And for that, we also want to protect the area around, since horses move around a lot and can get quite dirty in there. So you first have a clean leg with also no debris above it, so you might want to be using a brush, and afterwards you're going to have a friend holding the horse for you, and then you can apply the bandage. So I have in here a stack of cotton that I got from maybe one of those stacks that you get sent home with, and the idea is not to touch the surface that will be touching the wound itself. So what you can do is you could pick up the first sheet and just place it underneath, and then this way you have a piece of gauze that has not touched anything else. You also have in here white cling. This is supposed to stabilize the gauze once we have it on the wound. So what you'll do, let's say for example he has a wound up here, I'll be placing it flat and trying not to move it afterwards, and then we're going to place a stack of gauze and secure it with a roll of light blast. White cling, sorry. this is just support and just to hold the gauze in place. I apply just a very, very little amount of tension so that it will stay in this area. And I basically cover above and below the gauze and just keep rolling and rolling. Try not to have too many folds in there. And yeah, with all those layers that we're gonna be applying in this bandage, you always want to go in the same direction, because if you start unrolling the white cling in this way and then change again, you have more movement of the gauze underneath. So in the next step, you have your cotton sheet, which is going to be so that we can apply pressure, but it's not going to be causing harmful forces. And in the same way, since I've been starting to roll from outward inward, I'll be starting the same way. So I'll turn it around and have basically the amount of roll to facing like me. Then it's important to see that you also cover a bit of the heel bob here and end just about here. So you might have to play a bit with your ankle. So I'll start like this. And then make sure these ones fit inwards. And here. And just keep rolling. So it will end up looking like something like this. This next step, you're going to take your powder cling. This is where we apply our first tension layer. And with this and the following wet wrap, you're allowed to apply tension. It's in order to apply that much pressure that you can see the shape of the limb again, because that's how it's going to stay in place. So we can start with this and have even pressure at first. And then while I work my way down, I always apply pressure when I'm about here, so that I have pressure on the dorsal surface that's facing the front, not here on the back where we have our flexor tendons, since pressure source in this area can be very notorious to heal and cause also harm to the tendons. So I have just an equal amount of pressure here and more pressure down there when I'm about going around the front. So I keep rolling. I might have to touch my cling here and yeah, and just keep working my way down, and you start to see and appreciate the shape of the lip again. And once you're down here, so you're gonna need about 2 fingers on the top and on the bottom, because with our tension, we don't want to cause any harm, so you will always have this protective layer of cotton sheet here. And then keep rolling, rolling, and work your way up again the leg. Once I get up to the front again, I'm just about to end here, so I'll just make sure that everything is covered and looks nice, and then just stretch this out, and this is the first tension layer. Then we go on to what we call wet wrap, so it's adhesive, and it's also has a bit of tension that you can apply with this. Same rules apply. Tension you can apply when you come around the front, but never around the back. So once again, we start roughly up here and just cover once again our brown gauze, but not our cotton sheet. Then we'll just keep that in place, and as you can see, I'm getting a couple of wrinkles. So in order to keep a bit of tension here, and then I lay it on. This way, I get less wrinkles. And yeah, once again, pressure on the front, and then I go down, pressure on the front, and down, pressure on the front, and down. And we're going to aim for an overlapping of roughly 50% of your layers. And I'm just about here at the end once again. There. There. And then I'm working my way up again. Same principle.
roll, and what is nice if you have it ending just about here, so that when we now apply our final roll, we can also cover this end. It's supposed to stick to itself, but it's sometimes nice just to fix that end piece. Once you come to the wet wrap part, or even now the light blast part, you can take off any gloves that you were wearing earlier when you were dealing with the wound itself. So that's especially true for gauze and the first layer, so the white cling. This is the part where it's really important to have clean hands. And now for the cotton sheet, and once you get to the brown and the wet wrap, you can take your gloves off since it's a bit harder to apply. Now the final part that we sent home with you is called light blast. It's also written down here in case you don't remember. And you can get this part or a similar part also at Irvine's. However, this, what makes it so unique is that it's kind of stretchy and will self-contract on itself. So it's important not to apply any force while laying this on. Light blast, we like it especially since it's very easy to apply. And it's basically in order to cover the top parts and the bottom parts so that we don't have any dust or dirt that can work its way inwards. So we want to apply roughly one layer of light blast underneath, cover the white part, and not quite one layer of light blast above. So on here, going round the leg, and I slowly start working my way up. As soon as we can come in touch with the skin, it's really important not to apply any force. So I'm starting about here. So what I do is I kind of roll it up, let it relax, and then just lay it on. So once again, cutting, and just laying it on like that. Then I've also included the end of my wet wrap in this, so everything stays hopefully in place for the next couple of days. So again, starting here. Now that since we covered the heel bulb with our cotton sheet, it is not as mandatory to not apply pressure because also it's a bit hard to see underneath here, but it's still nice if you don't have any tension. So yeah, sometimes what you need to do is you need to come a little bit around the heel bulb because also since we have this gap around here, dirt can still work its way up. So what I do for that is I just roll up a little bit more and then just go really low. And sometimes you can even pick up the leg and just make sure with my fingers that it's on there and cover it as well. And then I end once again out here. So now with this we can appreciate the shape of the limb. That tells us we have enough pressure, and yeah, it should be good to stay on for 2 days. Normally we stay to maximum 3 days in order to change pressure bandages that were put on in order to protect any operation sites, just because with that change we can also make sure that nothing has slipped down. This way we can also regularly inspect our surgical sites for any kind of swelling, bleed or discharge. Should you have any concerns, obviously feel free to give us a shout and maybe send a picture or two. So yeah, this is how to apply distal limb bandage. And for the hind limbs it's going to be a bit harder on you since they have a bit of a different angle. But for the cotton sheet, same rules apply. You just roll and keep the same direction as you did before. And yeah, you can even have like a third hand in front in order to help keep it in place. But it's quite straightforward once you know where to start. And we're happy to show you anytime. Thank you. Thank you. Any questions? I'm happy to take afterwards. Sure. Yeah.
What was the layer that you put on top of the cotton sheet?
So the kind of dark pink brown part, yeah, that's what we call brown cling. It's just different from the white cling that was kind of the first part. But yeah, we call it brown cling. It's a cotton like material. Yeah.
Is it different than the white?
Yeah, so the white cling, once you feel it, I mean, when you pick up a horse from us and it has a bandage on, well, bring a couple of bags. Yeah, but so the white cling itself, it's roughly about just this size, and it's very small since you only will need it in order to keep the gauze in place. However, with the brown gauze, brown cling, forgive me, it's much bigger of a roll, simply because we're really covering almost all of the cotton sheet, and it's really in order to supply tension, because once you feel it, it also has a bit of different stretching qualities. You're welcome. Enjoy.
So that's your next slide. There's a laser there. So for your videos, just click next and we'll start playing.
Hi there, everybody. It's nice to see a lot of familiar faces out there. Thank you guys very much for coming. Yeah, we really appreciate our clients. I feel like we have the best clients possible at our clinic, and so yeah, we're happy to have you guys out today. So, woo! So yeah, I think a lot of you I have met. I am one of the surgeons at More Equine. Obviously, my name is Jennifer Fowley. I've been at More Equine since I was 18 years old, which was 2 years ago, a lot of years ago. So it's a home for me. So yeah, today I'm talking about pre-purchase exams, or PPEs. So yeah, hopefully give you a few interesting tidbits here. So a pre-purchase exam involves a few steps. So one, we're getting a history. We're doing a very thorough physical exam and palpations of the horse. We're doing a lameness exam with flexion tests, radiographs, plus or minus radiographs, and then potentially some additional tests after that. So we'll kind of go through each of those categories one at a time. So obviously as the client, as the buyer, you're coming into it thinking, should I buy this horse? And at the end of the exam, you're hoping that I'm going to tell you the answer to that question. So we're trying to have a crystal ball that we can look into. I haven't found this crystal ball yet, but I've worked for almost 20 years now trying to build a crystal ball. So basically, you're trying to gather any information you can about that horse so that you can know how to care for that horse, pending that you go ahead and buy it. You're trying to find out if there's any medical concerns. I think one misconception is sometimes at the end of an exam, someone looks at me and says, so how high do you think this horse can jump? Can it jump 1.60 m? And, I often say, well, how high can you jump? I can't really predict how high you can jump. I maybe have some ideas. But I think, in a way, there's a whole other side to buying a horse, which is can the horse do the job that you need it to do, which we can't necessarily tell that, obviously, from a 1-hour exam, how talented they are at the area of things, how fast can they run, those types of things. But yeah, so there's this kind of, the old school way of thinking of it was pass or fail. So at the end of the exam, the vet would say, this horse passes and this horse fails. Honestly, I don't think about it that way, because I think it's just not that simple, honestly. You're trying to put all this information together and figure out what are the risks that you're taking with that horse, and is that risk within your comfort level, all those things. So there's a lot of factors to think about. So yeah, it's not quite as simple as pass or fail. So we're thinking of it. I think of it like, that we're a detective and we're going to look, with a magnifying glass and collect all the clues we can and then give you some ideas. So So obviously we start just by identifying the horse, obviously, you know, the age, the breed, the color, those things. We'll often include pictures of the horse so that, you know, it's very clear that what horse we were doing the pre-purchase on. And then the history part for me is really, really important. So if you're trying to predict the future of this horse, it's really valuable to know the past. So you know, I often, I find I ask the seller so many questions that at some point they give me this look, and I feel like they all give it to me, this look of like, why are you giving me the 5th degree here? You know, why are you quizzing me? You know, a lot of it is trying to understand, you know, how long have they been in what level of work, you know, what have they been showing at, you know, what level of you know, speed or height or all the different categories, how are they doing? You know, obviously any history about any behavioral issues, any lameness issues or medical issues, you know, have they had a surgery before? Have they had an injury? Have they been having their, you know, a lameness exam in the past? You know, it's sometimes funny, you'll ask somebody, you know, has the horse ever had any lameness? And they'll say, nope, never been lame, not a step lame in its life. And then you ask the next question, you know, has it had any joints injected? And they say, oh yeah, it's had its coffins, its hocks, its stifles. It's like, oh, okay. So sometimes you're trying to put the picture together, right? And honestly, sometimes I'm trying to figure out how honest the sellers are being in this moment. You know, sometimes you have a few ideas. In general, I find people are very honest because it's a small world, which is nice. But you know, we're trying to ask all the questions in the right way that we get all the answers. You know, obviously it's nice to know vaccines, deworming, teeth, partly to know is there, you know, any risks there, or how do I put them into the schedule at my barn, you know, onto the vaccine deworming schedule. So yeah, sometimes, you know, the seller will say, oh yeah, it's just been hanging out in the field for the last 12 months. And you think, is that a red flag? You know, why, you know, that's about the time a person might rest a suspensory injury or something like that. So sometimes, you know, there's some, you know, question marks of why. Sometimes it's because the owner had heart surgery, and you know, there's other aspects. And I would say one thing that's not uncommon is that the seller isn't super prepared. So we're trying to ask, you know, when did they have their hocks injected? When these things happen, and they say, oh yeah, I can't remember. I don't know when it was. I could try to call the vet and find out. And honestly, it's just very helpful if the seller, even coming into it, has things kind of organized and knows the history there written down. It just makes it a lot easier for everybody when we're trying to track that down. So physical exam. So definitely we're doing a very thorough, you know, our detective with our magnifying glass, looking for any concern. So looking at their heart, lungs, abdomen with a stethoscope, looking for any skin lesions like sarcoids, melanomas, things like that. Looking their eyes, their ears, their nose, their mouth. You know, looking for dentals, missing teeth, cataracts in their eyes, all sorts of things. You know, in a way, we do look at the external genitalia for potential reproductive things, jugular veins. You know, it's always nice to know if they've previously had a jugular vein that has thrombosed and now you don't have access on that side. Lymph nodes, you know, all those types of things. You know, we always can pick up some interesting things. Like I would say this year, I've probably picked up 5 horses with heart issues on their pre-purchase, some with arrhythmia, some with murmurs. So some of those things are things that maybe as a owner or client you wouldn't necessarily know without having a stethoscope or those things. So while I'm taking the history, actually my eyes are like scanning the horse. So I'm looking to see, you know, is there joint effusion, swelling, muscle asymmetry? You know, I guess probably a lot of you could maybe think that this horse has something going on in this leg here. So sometimes it's more subtle than that they just tend to stand with one foot pointed a bit. Honestly, the lame foot can often have a bit more contracted heels or be like a narrower, smaller, more upright foot. You know, sometimes you'll see footwear like where they're wearing off the toe on paralogic horse, or even like a hock sore horse can do that. You know, looking at conformation. So, you know, at the top here is a kind of toed in, what we call varus fetlock, where the legs kind of angle in from the fetlock. You know, this horse kind of a long sloping pastern here, kind of that low underrun heel. You know, this horse has some muscle asymmetry, some, you know, muscle loss on that right gluteal area. I kind of went through, there's a nice lameness textbook that goes through different conformations and what potential lameness they're associated with. It's been a bit eye-opening in my career. Sometimes you have horses that come in with just terrible conformation. I'll never forget, I went to Kentucky one time and went to a Coolmore stud, and there was a stud, I won't name his name, but he was worth, you know, some $30 million, and his feet were terrible. I thought, oh my gosh, he's making babies by the dozen with these terrible feet. So, you know, that horse obviously still earned $30 million worth of value. But so conformation is interesting. You know, as a vet, I probably was actually more picky as a younger vet than I am now, but it's something we think about. So, so toed in, I don't love. I think they can have some more arthritis issues. The toed out can be better, honestly, but if it's quite severe, they can get interference or medial splints. This more upright pastern can have some more foot lameness or SDFT tendonitis. Long pasterns, a little bit more fetlock arthritis or P1 fractures. You know, some of the carpal conformations, so this carpal varus is like the cowboy kind of bow-legged appearance. Can definitely receive a little bit more arthritis in their knees, or splints, medial splints. Carpal valgus is kind of the one interesting thing in racehorses. So this is where the leg is going out below the carpus, that those guys had actually less knee chips. So that's kind of interesting. The offset knee, this one at the top here is the offset knee. So you see the radius comes down, and then you go sideways, and then go down to go down the cannon bone. So those can have some more fetlock, carpal lameness issues. This conformation I am a little more picky on. It's very straight hock, you know, very straight through the stifle, looking from the side. More suspensory potential issues, you know, even upward fixation of the patella, those types of things. And then the sickled hocks can be a bit more prone to hock arthritis or curves. So yeah, so there's a lot of information for you. Interestingly, we sometimes see horses with not great conformation that just you know, kick butt and don't care that they don't have perfect conformation. So, so at that point we go on to the musculoskeletal exam. So we're really going through every leg as well as the neck, back, and pelvis. We're palpating for range of motion, for heat, swelling, effusion, or pain. So I have a fair number of videos. Hopefully these will work okay. So, so this horse, as I go down the neck, as I get to the bottom, you see the horse's muscles are fasciculating and trembling. So sometimes horses just don't want you to touch them, so they react or move away from your hand. But you see at the upper neck, the horse seems fine. As soon as I get to the lower neck, the horse is showing a pain response, looking at me, you know, asking me, please stop doing that. Please stop taking the video. You already know. My neck is sore. So some of these videos are old. I was trying to pick ones where people wouldn't recognize their own horse in the audience here. So this is from my residency. This is a horse with SI soreness. So you can see, yeah, the horse is quite sore, trying to get away from the palpation there. One thing we see that the pain response is repeatable. So I mean, horses are trained to move away from pressure. So if you poke them in the side and they move away, that's also a normal response. So we see that it's an actual true pain response, not just that they're moving away from pressure. So this is another horse with hind suspensory soreness. So as I squeeze on its suspensory, you can see he's saying, please don't do that. That hurts. Very repeatable reaction in this horse. Hoof testers. So yeah, hoof testers are super helpful. We go around and test the different areas of their foot. You know, kind of coming around in that first on the side here, coming around the walls here, we might pick up signs of abscessing, bruise, fracture. When we're really in the toe area, so this middle one here, we are thinking about laminitis or thin soles. And then the terrible N word, we try not to talk about in a pre-purchase especially. Navicular pain potentially. Obviously these are not diagnostic, but it's a clue of that maybe the horse is sore in that area. When I was an intern, Dr. Mike Scott, who a lot of you guys probably know, he gave me this book to read. And I thought it's a very nice quote in here that's the first thing that you ought to look for are his feet. Just as a house would be good for nothing if it were very handsome above but lacked proper foundations, so too a war horse, even if all other points were fine, would yet be good for nothing if he had bad feet, for he could not use a single one of his fine points. So that was written in 1893. I think it's still very true today. And I often laugh is that my dad will send me a picture of a horse with tall grass covering the feet. And he'll say, what do you think of this horse? Should I buy this horse? And then I always bug him about it because he knows I'm going to ask for the feet. But thanks. So often we'll do a quick neurologic exam as well. So looking at the range of motion of the neck. Horses can have arthritis or soreness in their neck that can lead to pressure on their spinal cord. So we're looking for those types of things. We'll take them in tight circles, back them up. These things are telling us that they know where their limbs are in space. So a neurologic horse is kind of like a person who's had too many drinks at the bar. They start to not know where their limbs are in space, is how I think of it. So yeah, the other thing I think is nice about backing up is shivers. So shivers is a neurologic disease that often can show up when you're picking up the hind legs or backing them up, where they'll lift their tail and tremble, like kind of shake their tail. So we try to do that on every pre-purchase so that we're not missing things. All right, so now we're finally getting to watching the horse move at this point. So at a walk, I try to look to see, how is the foot landing, if they have sore toes, they want to land heel first. If they have sore heels, they want to land toe first. Do they paddle the legs, wing the legs? Not necessarily that we would fail a horse per se because they paddle a bit, but part of the whole picture. And then we're watching them at the trot. So we're typically grading them on a scale of 1 to 5. This typical front end lameness, you're looking for the head nod. So if you think their head and neck has weight to it, so when they have the sore leg on the ground, they're going to try to unweight that sore leg. So the head is going to go up. So the head is going to go down when the good leg is on the ground, or the relatively good leg. In the hind end, I often do this funny, I'll show you here in a second. so if I need a right knee replacement, when I step on that, I'm going to lift my pelvis up. So if this knee is bad, I'm going to lift my pelvis up and then go down like that. So it's that same motion you're looking for, obviously, hopefully more subtle than that in your horse. So we're looking for also the stride length, stiffness, reluctance to move, how they're kind of propelling themselves. So I love doing pre-purchases at our clinic too, or anywhere where there's a nice flat, hard surface, because you can actually hear something almost more subtle than you can see it. It's been interesting. So we do like to watch them at the canter as well, so make sure they take the leads nicely, they're holding that canter lead, or lope, as you say in the Western world. So looking for stride length, comfort, ease, how nice it is. Honestly, the trot is the best way to pick up a lame horse. If you want to know if they're lame or not, watch them at a trot. But canter is always good. So it's very common, we'll watch a horse go and the owner will look at me and say, do you think it's the stifle? and it's funny sometimes at that point, because I've already palpated the stifle or done things that have helped me know, I might have some ideas. But the truth is you can't really just watch a horse move and know exactly where in the leg it's sore. You can know which leg it's sore, but not necessarily which one. So we do, we do see scenarios where certain things, patterns show up. So, hawk horses are kind of stabby in their gait. Stifle horses might have this decreased flexion or dragging toes. Biceps or shoulder horses have a shortened anterior phase of the stride. Navicular, they look like they're on eggshells, this short kind of choppy gait. Suspensory, often the outside leg on the circle, it's not very snappy, kind of looks like this swinging leg lameness. So there are patterns that we see, but to be very honest, even the people who write this textbook, the lameness textbook, still would be proponents of blocking a lame horse to try to be sure where they're lame from. So no matter how long and hard you do this, you can't just say, oh, for sure that horse is sore in the stifle just by how they move. So this horse here is got a funny movement of its left hind. You guys see that, how it kind of slaps down on the ground? So instead of stepping forward where you would expect it to, it kind of goes backwards and slaps down. So this horse has an old injury in the hamstring area here, so scar tissue there that causes this funny gait. Interestingly, unless you're a dressage horse that's going to get marked on your walk, it actually is not a painful issue. It's just a mechanical lameness. So sometimes we pick up kind of interesting things. This horse here, as we're watching it walk, the hind fetlocks are extending further than we would like. I don't know if you guys can see that. I'll do it one more time. So this is kind of a hyperextension, or the fetlock is dropping too much. This horse actually has degenerative hind suspensory ligaments. So this is more typical front end lameness. So you see the head nod there. Anybody have a guess which leg this horse is lame on? Right front. Yeah. Did everybody get that right? We can go back again. So down on sound. So I'll say down, 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 left, left, down, down, left, left. So it's landing hard on the left. Therefore, it's landing softer, head up on the right. So this horse is lame on the right front. Okay, another horse here. Hind limb or front limb? Hind limb, yeah. Left hind or right hind? Left hind. Yeah, very good. You guys are great out there. You don't need us vets. You got it. So you see that left hind is taking kind of a hitchy, very stabby, short stride there. So very good. So hopefully in a pre-purchase at this point we haven't found much lameness. Honestly, it's not unusual that we find some things lameness-wise, but we're gathering information. So here we do our flexion tests. So we do a low flexion test and a high flexion test on each leg, where we hold the leg up for a minute and then trot the horse off. And it's the same like the doctor pinching your wrist and saying, does it hurt when I crank your wrist like this? And a person can say, yes, that hurts when you do that. Horse can't use their words to do that, but if they trot off more sore after you've stressed that region of the leg, then they're telling you, yes, that area hurts. So here's a horse, actually the same horse from the last video. So we've just done a hawk stifle flexion. I actually left the sound on that video on purpose, so I'll do one more time and have you guys listen for the sound too. So I think you guys can see the left hip is going up higher, so a hip hike. Yeah, you guys hear a soft sound and a loud sound. So the lame leg is making a softer, quieter sound, and the the other leg is making a harder adjustment. Okay, so at this point, I often have kind of a regroup with the client. At this point, if they're not happy with what we found so far, you can walk away. You can say, yeah, this isn't the horse for me. I'm going to walk away. You can proceed with x-rays. And I always say that the x-ray isn't going to erase the risk you've already found. Even if they have normal x-rays, if they're still lame, they're still lame. There's something causing them to be lame, right? So the radiographs could increase your risk, but it's not going to necessarily decrease your risk. There's the odd time where we recheck the horse in 2 or 3 weeks. Sometimes we go to do a pre-purchase and randomly the horse is really lame that day. And we say, I don't know what it did last night in this paddock, but we're going to come back in 2 or 3 weeks and look at it again. So I think it's fair to do that and keep that in mind as an option. So x-rays, we're looking for signs of arthritis, OCDs, navicular disease, chips, injuries, kissing spine, wobbler disease in their neck. You can take anywhere from 0 x-rays to 50 x-rays. Obviously, the more valuable the horse is, often the more x-rays we take. I think of it, as a cost. A cost-risk ratio. So the more money you spend, the more information you gather, the less surprises you're going to have down the road. But obviously it costs money to do that. So you're trying to balance those two things. Often people might ask, well, can we just take one view of that joint? Sometimes you'll miss something, if you can only see the chip from certain views. So we'll keep that in mind, that usually if we're going to take a joint, we like to take 3 to 5 views. You're gathering information to lower your risk. For ultrasound, it's pretty uncommon that we do that. Some of these $500,000 horse, the jumper world and that, where they want to ultrasound all 4 suspensories. One, it takes a long time to do a good job of that. I mean, if the horse is worth it and the time is worth it, that's fair. Sometimes you'll see something that maybe was an injury when they were a year old, and it doesn't necessarily bothering the horse at this point. So sometimes that's hard to know if it's a healed injury. Did it just heal last week or did it heal 10 years ago? That can be a little bit of a gray area, no pun intended. But sometimes if we know they've had a medial branch injury of a suspensory, we want to just check that thing. Sometimes there's value in that. There are, especially these fancy jumpers, some of them are doing MRIs or bone scans on pre-purchase. That's pretty rare in this area of the world. I think there's a fine line to where you're getting a bit crazy. Coggins, just the additional tests here now. Sorry, I have no idea how much time I've gone here. Should have paid attention. So the Coggins test, tests for equine infectious anemia, they can actually be a carrier of it and be asymptomatic. So just because they're healthy, it doesn't mean they don't have it. If at some point they test positive, the government gets involved and they mandate that the horse is put down. So it's one of these things. It's kind of like getting hit by lightning. It's extremely rare. I've just seen a couple cases, none of them on pre-purchases, but a couple positives in my career. If then you want to take your horse to show at Spruce Meadows and you need to get the Coggins done or to cross the border and it's positive, now you have to put the horse down. That's obviously very upsetting. So it's a test we offer on all pre-purchases. Sometimes it's nice just to know at the moment you bought them they're negative. But like I say, it's extremely rare. Drug testing. So we can take blood and send it away for pain medication or sedatives. They can pick up if a horse has had a joint injected within the last week. They can't pick up if it's been injected 2 months ago. The other option, which I like, is that we just take the blood and we put it in our freezer and we hold it there for 6 months. So if the buyer or seller at some point want to run that blood and see if there was drugs in it, we can. In a way, I like the idea as veterinarians, if we just all do that on all pre-purchases, then people have the idea they can't pull any funny business. So So yeah, genuinely, in all the years, I can only think of 2 times where there was funny business on a pre-purchase. So I do think it is extremely rare, but some of these are obviously big purchases where you would like some insurance. So some of the other things that are less commonly done are things like just basic blood work, even potentially testing for Cushing's on an older horse. We can scope their upper respiratory system, more common in race horses, or if you'd heard a noise, a respiratory noise. This height, we do often just estimate the height, but say you would like to enter this in a pony jumping class and it's 14.3 instead of 14.2, and you bought the horse thinking it was 14.2. Some of those I would just recommend that you explain that to the vet, that you would like, a proper stick height done. Rectal exam would be very rare. Any of these things that are invasive or, even carry a tiny risk to the horse, the seller has to approve that. So if we're doing anything invasive, like the seller also has to approve that they're okay with that being done to their horse, because at that point they still own the horse. For breeding, really if you want to use the horse as a broodmare and want to really delve into that, a rectal exam and ultrasound would be beneficial. A genetic panel usually is you don't have time to get it back in time before you're having to make the decision of buying the horse. Gastroscopy also, is an invasive thing, not that common to do. I put this on there that we do have a quick look in their mouth, but we're not doing it with a speculum where we can palpate each tooth or look with a mirror to make sure there's not a crack on the back tooth in the mouth. So we do just a quick look in the mouth, but not a thorough one. So a few take-home messages. I would say we're still looking for that perfect horse. You guys let me know when you find them. But it is, so that's where this pass-fail comes in, right? I mean, it's really hard to find a horse that you literally don't find a single thing, but you're trying to figure out, in a way, does it pass for that client? Is this horse gonna fit with that client's level of risk and that? So I think behavior is a big thing to think about too. Sometimes we do, the horse might just look awesome and super talented and everything good, but they're, it's got a bit of a pushy, bad attitude, and they're trying to buy it for their 7-year-old daughter, So sometimes as a vet, I sometimes wonder how much of that is our territory to talk about, but in a way, it's technically, we're not often signing off on that. We think, this is a safe, nice horse, that a lot of that is the owner's decision. The more history you know, the better. Honestly, I love it in a way when we have, in-barn sales. I'm looking at a few people I know here, where we've done pre-purchases within the barn and they've been, riding that horse for 2 months before they even are buying it. I mean, that is so valuable compared to knowing a horse for 1 day. Having a trial ride with the horse is great, to know that you actually kind of get along with the horse likes you. This idea that we can't make guarantee, we obviously, this saying that the horse could go break its leg tomorrow, we're trying to really assess risk for you guys, but we can't guarantee that things are not going to change over time or those things. But I still feel it's a very valuable way to obtain a lot of information, and also I think honestly we can tailor that to the budget too. So I think sometimes people think, oh well, it's only a $5,000 horse, I'm not going to do a big pre-purchase, but sometimes even just the exam part of it without the x-rays, you can get a lot of information there as well. So if you buy a cheap horse that then costs you a lot of money trying to keep it sound, then it's not a cheap horse anymore too. Some people ask me, this is a good question, so when we do a Coggins test, we don't get those results back for 2 days, but often, they're at the clinic and the horse has now gone into the buyer's trailer and gone home with them. So just to be watchful that in the contracts, that if there's something that's getting followed up on, that it's in the contract saying, if this horse God forbid, came back positive Coggins, that the sale would reverse, or some of those little details. Yeah. So sorry, this is just one last video for you. This is my 7-year-old son. This is our 18-year-old quarter horse Chex, who's just the most angelic horse that you could ask for. He's a little bit lame in the right front. I don't know if anyone picked that up there. A little bit lame in the right front. But yeah, I mean, he on paper is not worth very much money, but for me to be able to trust my 7-year-old son on there is invaluable. So yeah, with that, I'm happy to take any questions. Yeah. Yes.
Just a basic question, what is the starting price of a PPE? I know it can go up higher the more things you have done.
Yeah, so the exam part is in around the 500 range, and that includes the physical exam, the lameness exam, and a report. So we give you a big written report. Yeah, and then once you start taking X-rays, you start adding on there. Yeah. Yeah. Yes. Yeah. So the question was a young horse, what kind of PP? I think we still can do a lot of the same things. There's some where we end up just watching them loose in a round pen, versus being able to do all the flexion tests. A lot of them we can still get that all done. It's interesting, in a young horse, the OCDs, like the chips in the joint or the developmental things, might be there, but not showing you clinical lameness yet. So it's not uncommon in a young horse, especially an expensive young horse, that we do a radiographic screening looking for those OCD things, because they actually might still be sound even though they have chips. So it's kind of interesting. The risk, as they get into more work and have done more, then you actually feel a bit less risk, because a lot of those things would have shown up clinically by then. It is. There's lots of young horses that we would still do a pre-purchase on. Yeah.
So in a young horse, say if you found that your joints were loose, they were quite movable.
Yeah.
Is that a concern?
Especially like foals and young horses, there is a normal amount of laxity, I would say. So yeah, I think the vet should be pretty comfortable saying, is this within normal? I would say it's very, I can't think of many cases where that would come up as a concern, as a clinical concern. Yeah, I would say more so in the warm bloods, or the ones that are maturing later. Yeah.
So it's a maturity.
Yeah.
After an exam, regardless of the cost of the horse or cost of the exam, are you guys willing to say yay or nay, or give this horse a 60-40?
Yeah.
Or is it totally the buyer's?
That's an excellent question. I find sometimes I'm explaining all the details, all the risk, and then I see the owner looking at me. Okay, Jen, just tell me what to do, And I've also learned that the way I present the information also implies, how worried I am and how risky it is. And I think also when you get to know your clients, there's clients that I've worked for years and done tons of pre-purchases where I just say, no, you gotta keep looking. One thing I didn't write in here because it's a bit more gray too, but even just the cost of the horse can sometimes change during a pre-purchase exam. So if we find something that really would change the value of that horse because there's quite significant risk, sometimes then the buyer and seller go have that discussion. As a vet, we try not to be involved too much in that discussion, but sometimes that is part of the direction that things go. But for sure, we get it. We're trying to, you guys want a yes or no answer, right? And it is gray, so we are trying to give you all the information we can, and I find by the end of it, it's usually the owner's pretty clear, okay, yeah, I'm comfortable with this risk, or I'm not comfortable with this risk. right. Thank you guys very much.
Okay, thanks, Dr. Fowley. We just have one more little to-do or skills on iMeds. So giving iMed sources is another one that we get a lot of questions about. Might help with Dr. Lemon's talk with those crazy eyeballs that she showed. Oh my God. Yeah. So.
Hi, I'm Welf, one of the intern veterinarians here at NORS, and I will be talking about some things that are important related to eyes on a little how-to today. First of all, it's important to understand when there's a problem with the eye, and there are 3 main symptoms that horses will show us. First of all, when there's squint in the eye, just having the eyelids more closed than usually, that's one of the big symptoms. The next one is discharge from the eye, which can have different qualities. It can be serous, mucus, purulent, hemorrhagic, all of these things. And then the third big one is if they're moving away from the light with their eye, and the light makes them painful, that should give us a concern as well. These 3 symptoms are not always, can be less significant and hard to detect. They can be quite subtle. Maybe they'll just be closing their eyelid a little more than usual, and you have to take a second look. There can also be just some swelling, some puffiness that should also give us a concern. If you notice any of these, that means there's something wrong with the eye, but at that point we don't know what. And it's very important to get an accurate diagnosis, because there are different diseases of the eye that can have the same symptoms. They can look to us the same, but they will be treated very differently. And there are eye medications that can be good to one condition but detrimental to the other, also looking the same from the symptoms. So if you notice any of these symptoms, it's important to get an accurate diagnosis, and that will be done by a veterinarian who will do an ophthalmologic exam, and they will find out what the diagnosis is. And oftentimes they will prescribe eye medications afterwards, depending on what it is. And I will show you how to administer these eye medications. There are different ways of doing them. I will just show you one way today here. If you're by yourself, it's a little harder than having a companion, but the first thing is to put a halter on the horse. And then you'll have a tube that kind of looks like this. You want to put about a quarter strip of this eye medication on your finger. And then I like to put the head of the horse on my shoulder to kind of restrain it a little bit, and have my right hand around the head. And you want to have clean gloves, and open the eyelids with your thumb and your third finger, and then put the medication into the conjunctival sac with the second finger, and then the movement of the eyelids will disperse the medication on the cornea there. You can notice that when seeing kind of liquid surface, or like a fatty surface, it looks like, because that's usually what these medications are based on. If you have a second person, they can hold from the other side, especially if it's a horse that has gotten eye medications for a long time. they usually don't get better with getting them. And they can hold from the other side, and then you have two hands. You can open the eye with the right hand like this, and then have the left hand to apply the medication. It's quite helpful to give the horse a treat after you give them the medication. That will usually give you an easier time next time, or at least not a harder time.
Super easy, right? Everybody? Super easy. Oh, I missed that. What was that, sorry? Right? Yeah. It's the most perfect horse we could find for that. Yeah. No, eye medications are one of those things that can just go so badly so quickly. Some horses really resent it. That horse obviously didn't have an eye problem, so the eye wasn't painful or swollen or half closed or whatever. So yeah, eye medications it can be really, really tough. We do have other options. Some horses can get actually quite dangerous too if they're having to get it. Like some of these cases need every 3 hours treatments and things. So we can have them having different delivery systems that we actually put into the eye that you just, stand by the horse's shoulder and the little tube kind of runs into the eye. So do have other options, but yeah, eye meds are one of those things that can be really difficult. Do you have a question? Okay, so this question on what can you put in a horse's eye. If you're happy to put it in your eye, then you probably are okay to put it in a horse's eye. People put all sorts of weird things in horse's eyes, but that's usually what I think. I'm like, if you're comfortable putting it in your eye, then you could probably put it in a horse's eye. I always tell people, just an over-the-counter eye antibiotic ointment, so there's polysporin for eyes, or pink eye, or whatever. Those are, you can pretty much put those in any eye and it won't hurt the horse. It might not do anything if it doesn't have a bacterial infection, but you're not going to do any harm. Yeah, I have never put the polysporin for skin in an eye. What it will do, I don't know, but try to get the ones that's made for eyes would be the big thing. Just be careful of steroids. Steroids is really the big thing we get excited about. Putting anything that has a steroid in an eye, if it has an ulcer, will make it way worse. So that's really the big one you want to avoid when you have eye meds. But okay, so any more? Oh, lots of questions. Kate, yeah. Is there any way to check vision after an eye injury? For sure. The hard part in horses, we have a little bit more tests in small animals looking for acuity. So in people, we have the, read the letters or whatever. You can't really do it with horses. So usually it's more of a yes-no situation. Can they see, can't they see? So typically we have what's called the menace response. So anytime any animal sees something come towards the eye, they should blink. So that's the big one, to say yes they can see, no they can't see. So just coming straight at the eye, they should blink. The only ones that don't do that are like babies, like newborns, but everyone else should do that. So that's more of a yes-no situation. Usually the acuity comes down to what can we see. Does it have a cataract or something like that in there that we know is going to be affecting the vision? And usually you'll start seeing called moon blindness, or they start going really cloudy inside the eye. So you know that there is going to be some acuity loss in those eyes, but that we don't have the best acuity tests in horses, unfortunately. Yeah, I remember in small animal they have like the cotton ball test. You drop a cotton ball and they look at it, but we don't have things like that in horses. But another question. In a pre-purchase exam, can a vet see moon blindness? Yeah, they should be able to assess that, yeah. Usually horses with moon blindness have some pretty severe vision loss. So if you have horses that really can't see, you know, they're having their eyes are wide open, you might be able to see some moon blindness, so see that cataract in there too, they should be able to pick that up. Usually we can see pretty mild cataracts to very severe cataracts because we are usually, in most pre-purchases, we're having our ophthalmoscope and actually looking in the eyes, so to assess things like that. So we should be able to see that, yeah. Yeah.
Is there any testing you can do to see if they're like predisposed to get it later on?
Predisposed to getting cataracts?
No, like to getting moon blindness.
So like a uveitis leading to moon blindness, is that what you're thinking? So uveitis is just inflammation in the eye, leads to early onset cataracts. So usually there's breed dispositions for those things. So we will see that and often have conversations with that. But there's also the same breeds like Appaloosas and things like that tend to be predisposed, but it's not for sure they're going to get it. So until you see it, then you're not going to really know if that horse is predisposed, other than just knowing it's more susceptible in certain breeds. Again, that history piece is really important. If you know, or if the seller is going to be open about whether they've had some flare-ups of that uveitis previously, would be disclosed, and that obviously would indicate some potential. But anyway, oh God, I had to think on my feet on that one. Okay, I think I'm the only one left to go, I think. So I am going to talk about something super exciting. So we are in the midst of starting some fun development at the clinic. Is that going to go? I'm just going to go through this quickly. It's a pretty quick presentation, and then we'll get into the rest of the door prizes. Oh, perfect. Oh, clickers here. Okay, cool. So we are in the midst of building a new building, very early stages, which I'm very, very excited about. So this is the first kind of expansion at the clinic at our north location. Been there since '93. So we're building a new building. And this is one of the big reasons we're building a new building, is because we want to get in a CT, so a CT scanner. So I want to just touch on this to kind of introduce people to it. Probably won't be till early 2027, I'm going to guess. End of 26 maybe if we're lucky. But this is really, the next big thing that's coming down for us, in addition to some of our other machines that we already have. So at Moore, if you've ever been to the North Clinic, it's a fairly big campus that we have there. And we do have a couple fun diagnostic machines up there. So our CT scanner is kind of going to be a next step in doing some of these diagnostics for us. So right now we already have our bone scan or nuclear scintigraphy. I know some of you have seen this before personally, and had your horse in it. So it's really the only way that you can kind of scan a whole horse and look for areas of injury and arthritis that sometimes we can't find any other way. So we already have that. We've had that for 20 years, 25 years maybe. We've had that diagnostic at the clinic, which has been great and been really helpful to horses in Western Canada. We even get horses up from the States as well that will come to us to use this machine, which is great. So it's been very, very helpful. We also got we have a standing MRI. So as well, we've had that for about 10 years now. So again, that's standing. That's been really, really, really good for us too, and helpful for horses in the area to diagnose some of these soft tissue injuries in the lower limb. So that's been very, very amazing to have. So the next step in these diagnostic machines is getting a CT. So it's a crazy big machine. I'm not going to talk about how expensive it is, but it's going to be amazing. So I'm so excited. If anyone knows me, I love teeth. Teeth and heads are my jam. This is like revolutionizing to me because every time I go to a conference, I hear about dental vets that get to use CTs and how helpful they are. So this is going to help me certainly immensely with a lot of my cases, but certainly helping with bone and joint diseases as well. Also pretty amazing for necks as well. So I'm going to go kind of show you some differences when we look at these different things. So the machine we're getting, you can do it standing. So see that horse on the right there, just getting his head done, can just go standing. Also put limbs and things in just with sedation, so just putting different limbs and things into this machine. And it really gives you like a 3D view of these appendages when you put them in there, which is really great. So it's just, in a little bit later I'll show you some images that are pretty cool. So really it's going to help us find the problem, right? So you do still have to do kind of a lameness exam, or you do still have to kind of figure out where on the horse the problem is. But once you kind of have that localized, then this will be very, very helpful. So again, an advanced dental and sinus evaluation is going to be super duper helpful. Neurologic issues, so neck, back, spine, those type of areas we can't get with really anything else. Bone scan can help us kind of tell us where the problem is, but it doesn't necessarily show us the intricacies of the bones and the joints in the area. So this will help in that assessment. Pre-surgical and post-surgical planning, so fracture repairs, it's going to be huge to be used in fracture repairs, pre-surgery and post-surgery to make sure everything's in line. As well as hopefully in the future will be used for research and things like that. So advancing performance medicine, especially in horses, it's going to be pretty valuable. So here's the head. So your head rad is a very typical head radiograph that we'll take in that top right corner. A lot of shades of gray, a lot of overlap of bones and structures can make it difficult. We'll take multiple views to try to make it a little bit clearer, but at the end of the day, it's very limited in how we can evaluate the inside of the horse's head. With the head CT, it's basically like a 3D reconstruction of the head, both on the outside of the skull as well as inside of the skull. So you get just so much more detail on what's going on to be able to make a plan on treatment or surgery or extraction techniques or things like that that you need to do when you're evaluating the bones of the head and the teeth. So it's pretty amazing. And you can move these images all around, look at them from upside down and backwards and inside and outside. Oh, it's amazing. Sorry, I'm just super duper excited about this. So this is another big one. So again, common neck x-ray that we'll take in a neck. So head to the left, tail to the right. So that's just the top end of a neck. Same image on a CT. So you can just see the detail that you can see in a CT versus an x-ray. Again, moving it all around, different planes, cutting through it, that you just cannot see with an x-ray. Again, this is something we can't put in an MRI machine. Nothing else can really image it. So pretty amazing to have those opportunities. So really gains clarity and look at more locations as well. So you can do standing sedation, so you can do front and rear limbs and head and neck in standing. You can also put them under general anesthesia, so they're sleeping. You can get stifle to the hips, thoracic spine, the sacral joints, so your SIs, and the back, which is pretty amazing that you can get all that imaging throughout the whole horse, which is pretty crazy. So again, even getting amazing views of the chest, we just don't see this. This is like small animal world, this is pretty amazing that we can see this kind of detail in the horse and have this opportunity. There's just nothing else that we have that can do this. So it will really help our horses. It'll give us more clarity on how to help them, how to help you guys help them. And we're all pretty darn excited about it. So I just wanted to introduce that and get you all excited as much as I am. Our building will also have new surgical facilities as well, so we'll be upgrading those, more indoor stalls and stuff too for us too. So we're pretty excited about the build. So you might see, if you're at the clinic the next year and a half or so, you might see some construction, but just know that there's some big things ahead. So hope you all can be part of that. So thanks so much, everybody. That's all I have. But yeah, thank you all for coming. We'll just do